4, 3, 2, 1. We are live now.
Okay. Rameshwar, start.
Good evening, everybody. Today we are here for the first webinar of a new academic year of Indian Orthopaedic Rheumatology Association. I welcome our respected office bearer of Indian Orthopaedic Association, Dr. Atul Srivastava sir, Dr. Chadda sir, Dr. Anup Agrawal sir, Dr. Naveen sir, and all the faculties and respected speakers, our founder of Indian Orthopaedic Rheumatology Association, Professor Manish Khanna sir, Professor S.S.Jha sir, our speakers, Professor Chinmoy sir, Dr.Neeraj Jain sir, Dr. Pankaj Jindal sir, and our panelist for today, Dr. S.S.Lehkar sir, Dr. Dilip Muzumdar, Dr. A.C. Agrawal, Dr. A.N.Mukharjee. So here today...
You have forgotten our president-elect, IOA from Lucknow.
No, he said, sir.
He
said.
Dr. Chadda sir, president-elect IOA.
He talked about me, Vice President Anup. He did say, sir.
I sir.
Perfect.
Thank
perfect,
you, sir.
perfect.
Sorry.
No, it's okay. It's okay. Perfect.
So we are here today, and we are now starting our first webinar. I would request our new president of Indian Orthopaedic Rheumatology Association, Dr. Rajesh Gupta sir, to please say something about IORA.
I think I'm not visible now again.
But your voice is audible. So I think before your president says something, let Anup start with his few words.
Yes, sir.
Of blessings.
Actually, I have to invite only Anup to say a few things.
Okay. Please do that. Please do
Thank you, sir. Thank you, sir. Blessed to be in the first academic event of this academic year of IOA-IORA cell. And I'm really grateful and happy to see that how this rheumatology has been taken care by the stalwarts into the subject, Dr. S.S.Jha and Manish Khanna, and now Dr. Rajesh Gupta and Chinmoy Das are taking it forward. Just before the start, I was discussing that this is one subject which is needed, very much thrust is needed on this subject to teach every common orthopedic surgeon the nuance of diagnosis and the nuance of so many drugs which are coming up into the rheumatology. Which one to pick for which patient is really very critical. So I'll not come in between academics and you. Thank you for having me here. Once again, congratulations. And I can foresee that it's going to be a very good learning experience for all of us. Thank you.
Thank you.
Thanks, Dr. Anup, for being with us today. I wanted our president and the secretary to be here, but I think they promised they will join. They may join in due course of time. They are busy somewhere, I know that. And Dr. Chadda is also traveling, from Rajgir to Patna. He also told me he will join in between somewhere. So I must thank all of you, for giving us an opportunity to, to do all these activities. So this is our first, webinar of the series, and we will be having 4 to 5 webinars this year. So next we have planned is on gout, and then as Professor Jha, you are also saying, we will be going for seronegative spondyloarthropathies and all those arthritis, and maybe 1 or 2 more in discussion with all the IORA executives. So I think with all these few words, I will be presenting my first, talk of the series. So just let me know if it's visible or not.
Yes.
Is it visible, sir?
Yes.
Yes, sir. Yes, sir. Visible, sir.
Okay.
Make it full screen, Rajesh. Full screen kar le.
It is already full screen, I suppose. Just
right. You're right.
So I'm going to talk on etiopathogenesis and introduction of rheumatoid arthritis. So rheumatoid arthritis is a chronic, usually progressive inflammatory disease of unknown etiology marked by symmetric peripheral polyarthritis and systemic manifestations. Now coming to history, it is referenced in the text as far back as 4500 BC. The Native American skeletal remains from 5000 to 500 BC were examined and found to have evidence of rheumatoid arthritis. William Musgrave, the British physician, he compiled De Arthritis Symptomatica in 1715, which first described the symptoms of rheumatoid arthritis. Dr. Alfred Baring Gerard coined the phrase rheumatoid arthritis in 1859. So it is the most common form of chronic inflammatory arthritis. It is a systemic autoimmune disease affecting many parts of the body, especially the joints, leading to joint damage and ultimate physical disability. Till date, there is incomplete understanding of the initiating pathogenic pathways. And rheumatoid arthritic patients tend to die younger because of the cardiovascular complications. So the incidence peaks between 25 and 55 years of age. If it occurs between 16 and 14 years of the age, it is known as young onset rheumatoid arthritis. And if the onset is after 60 years of the age, it is known as the late onset rheumatoid arthritis. It affects around 0.5 to 1% of the population worldwide. And the prevalence is lowest in the Black Africans and Chinese and highest in the Paima Indians. Female to male ratio is 3:1, so it is more common in females. Now coming to stages of rheumatoid arthritis. Now stage 1 is the preclinical stage where there is a breakdown of the self-tolerance. Now what is self-tolerance? There is a failure of the immune system to tolerate the self-tissue. Now the autoantibodies, which is rheumatoid factor and anti-CCP antibodies, they are found many years before the onset of the clinical disease. It means that the immunological process must have started many years before the onset of the clinical symptoms. Now, second stage is the synovial stage. There's a vascular congestion with new blood vessel formation. There's a proliferation of the synoviocytes. There's infiltration of the subsynovial layer by the polymorphs, lymphocytes, and the plasma cells. And there's a thickening of the capsular structures, synovium villus formation, and cell-rich effusion in the joint. The third stage is a destruction stage. The persistent inflammation will lead to joint and tendon destruction. There will be articular cartilage destruction, periarticular bone erosion by the granulation tissue and osteoclast resorption, tenosynovitis and the tendon ruptures, swelling of the joints and the bursa. Now the stage 4 is a deformity stage. There's combination of the articular destruction, capsular stretching, and the tendon rupture will lead to progressive instability and the deformity of the joint. And what is the pathogenesis of it will be discussed in my later slides. Now coming to the etiology, till date it is not fully understood. It is considered multifactorial. It is autoimmune. The body loses ability to distinguish between the synovial tissue and the foreign tissue. Now coming to the genetic factors, it accounts up to 60% of the disease susceptibility. There is a strong association between susceptibility to rheumatoid arthritis and certain HLA haplotypes. HLA-D4, which occurs in 50 to 75% of the patient, have the poor prognosis. And HLA-DRV1 with positive rheumatoid factor carries 13 times greater risk of developing bone erosion in the early disease. The concurrence rate of rheumatoid arthritis is higher in monozygotic twins than in the dizygotic twins. There is increased frequency of disease in the first degree relatives. So coming to the environmental factors, there are some triggering infectious agents like mycobacteria, streptococci, the mycoplasma, rubella, and there is another, which is found in the oral cavity, Paraphorominus gingivalis. It is found in the patient with gingivitis, and it has been shown that it induces, the anti-CCP antibody in rheumatoid patients. Now, viruses, there's Epstein-Barr virus and the cytomegalovirus. The lifestyle factors, tobacco chewing, smoking, increase exposure to the crystalline silica. Now, there are documented proof that the smoking, what it causes is it induces, the mucous membrane in the respiratory tract leading to, the production of that thing, the peptidyl arginine deaminase, and which I will be discussing in detail in few minutes. And then it leads to all the pathogenic pathways. There's increased susceptibility postpartum and during the breastfeeding. Coming to the host factors, the association has been seen with type 1 diabetes and hypothyroidism. Now coming to the pathogenesis, I have tried to make it very simple. The genetic factors, the environmental factors, and the host factors in combination or in isolation, what they do is they induces the production of the peptidyl arginine deaminase enzyme. Now what this enzyme does is the arginine amino acid in the type 2 collagen peptide, it is replaced by the cerulinin, what is known as cerutination of the peptide. Now this changed peptide, cerulinated peptide, it is engulfed by the antigenic presenting cell. And the most of the time, this antigenic presenting cell is the dendritic cell. Now, once it is digested by this cell, some portion of this cerulinated peptide, it is presented over the dendritic peptide on the top. Is major histocompatibility complex type 2, and the major haplotype here is the DR4, which is common in Caucasians, and DR1, which is common in Indian and Israelis. Now this dendritic cell with a cerulinated peptide over HLA gene, it interacts with the T helper cells, that is known as CD4 cell, through the T cell receptors. And while this then is get there is autocrine effect on the T cell. So this T cell then divides into T helper cell 2 and T helper cell 1 and also T helper cell 17. Now T helper 1 is very important for cell-mediated immunity. It releases interferon gamma and interleukin 17, and T helper 2 stimulates beta cell for antibody production. And this is how it is done. The T helper 2 cell, it stimulates beta cell. Some of them changes to memory cell, and some of them changes to the plasma cells. Now, plasma cells, as we know, it is important for antibody production. So there are two types of antibodies. One is anti-CCP, anti-cyclic citrulline peptide antibody against the citrullinated peptide, and another is IgM antibody against the FC portion of the body's own IgG antibody. So these immune complexes, they are responsible for further pathogenesis. Now, all this process till now is happening in the mucosal surfaces and the central lymphoid tissue. Now, there is going to be second hit. These immune complexes, they travel through the blood to the joint. Now, in the synovial giants, there is a synovial membrane and it has many cells. It has many cells. So two important cells here are the macrophages and the synovial fibroblasts. So macrophages, when this immune complex is digested by the macrophages, it gets activated and there is a release of tumor necrotic factor, interleukin 1, interleukin 6, interleukin 8, and GM-CSF. What is GM? Is granulocyte macrophage cloning stimulating factor. And the synovial fibroblast, it creates one interleukin 6, interleukin 8, GM-CSF, proteases, and collagenases. All these cytokines are very important in the pathogenesis of rheumatoid arthritis. So the infiltration of the synovial membrane with the lymphocytes, plasma cells, dendritic cells, and the macrophages, CD4 cell lymphocytes, including Th1, Th2, Th17, they interact with the other cells in the synovium. The lymphoid follicles form within the synovial membrane, in which the T cells beta cell interaction leads to beta cells to produce cytokines and autoantibodies. The synovial macrophages, synovial fibroblast activation by the immune complexes leads to pro-inflammatory cytokines. there is a synovial membrane swelling, damage to the soft tissue and the cartilage. Now, the osteoclast activation by the rankle leads to destruction of the bone. Now, how it is done? The rank molecule is expressed by the osteocytes and it is activated by the interleukin 17. Chondrocyte activation by interleukin 1 and tissue necrotic factor leads to the destruction of the cartilage by MMP metalloproteinase. Tissue necrotic factor leads to regulate the production of other cytokines and activating endothelium. So there is increased angiogenesis and increased hyperpermeability in the synovium and within the joint. Interleukin 6 also regulates the systemic effects of rheumatoid arthritis by inducing acute phase response, anemia of chronic disease, fatigue, and reduced cognitive function. So inflammatory granulation tissue, which is known as pannus, it spreads over and under the cartilage, leading to erosion and destruction. Maturation of the osteoclast in the synovial membrane and the adjacent bone will lead to erosion of the bone, finally leading to fibrous or bony ankylosis. There is a muscle atrophy and infiltration with the lymphocytes, which will lead to biomechanical dysfunction. Rheumatoid nodules also occur in pleura, lung, pericardium, and sclera, leading to its systemic manifestations. And hyperplastic lymph nodes and bone marrow is there. Now, hallmark of the joint disease is joint inflammation, cartilage destruction, and the bone erosion. So this is what we see. There will be inflammatory cells in the synovium. There will be hypertrophic synovium, pannus. There will be thinning of the cortex and the bone.
You are not audible, sir.
Something went wrong to Rajesh's system. I think his net went off. Rajesh? Can you call him up?
Yeah, I'm calling, sir. Yeah, I'm calling.
Yes, audible now.
Audible, sir?
Bol, Rajesh, bol.
Audible, sir?
Yes.
Audible, sir?
Right.
Sir. Audible, sir. Yeah.
I'm joined with other computer. Which slide was the last slide?
Rajma.
Go ahead.
This one?
Next.
Yes.
Yes.
The phagocytosis and other things.
No, this one I have completed.
Yes,
Right.
yes, sir. You have completed this one. The next one.
So this
Yes, sir.
from here.
Okay,
Okay, no problem.
Okay, sir.
So
Yeah.
the hallmark of the giant disease is giant inflammation, cartilage destruction, and the bone erosion. Now this, again I'm showing here the synovial
inflamed synovial membrane, synovial fluid, pannus. Here, the major cell types in the the pannus are T lymphocytes and macrophages, and the minor cell types are the fibroblasts, plasma cell, endothelium, and the dendritic cells. But the synovial fluid has a major cell type as the neutrophil. So again, in nutshell, the antigenic presenting cell will stimulate the T cell, and the T cell B cell interaction will lead to the formation of the immune complexes. Immune complexes are finally digested by the macrophage, and macrophage will lead to the production of the interleukins and tumor necrotic factors, and this will stimulate synovites and chondrocytes and osteocytes, and there is a production of collagenases and other neutral proteases leading to the cartilage and bone destruction. Thank you.
Thank you, sir.
Very nice. Thank you.
Thank you so much. So now we can move
Sir,
to
I have tried to make it very simple. I don't know, it is very complex. You know that the pathogenesis is very, very complex. So I have tried to draw my own diagrams to make it very simple. I don't know.
It was good, sir.
No, sir, it is very good, concise information, sir. Now I request Professor Dr. Jha, sir, to please say about how to make early diagnosis and classification of rheumatoid arthritis. Professor Jha, sir.
Right. So I'm talking about how to make early diagnosis of rheumatoid arthritis and a kind of classification of the connective tissue diseases. Friends, I only wish to say that Muller handed over the charge of his hospital to Gange, and Gange described a safe surgical dislocation, which is so very famous. But at the same time, he also devised surgical strategies to treat the pre-arthritic hip. So as orthopedic surgeons, we are all connected with this terminology, pre-arthritic hip. Now, let us come to what Dr. Rajesh has just now talked about, the first stage, that is the pre-rheumatoid stage. And there are so many names given, very, very early, probable rheumatoid arthritis, very early rheumatoid arthritis, so on. But what is the widely accepted term to avoid confusion? And that term is pre-rheumatoid arthritis. This is for the evolving stage of the disease before clinical appearance of rheumatoid arthritis. Now, what is the principal advantage of early diagnosis of rheumatoid arthritis? It helps in deciphering future likelihood of rheumatic diseases and the therapeutic intervention about which Dr. Manish Khanna is going to tell us at this stage is likely to either abort the disease completely or achieve an early and sustained remission or minimum produce a low disease activity. So the early diagnosis of rheumatoid arthritis will be disease-related autoantibodies like ACPA and sometimes rheumatoid factor also, and maybe MCV also. Yes, Dr. Thakkar, welcome. Good.
Yes, sir.
Please.
You continue, please. You continue. I don't want to disturb in between.
No. You have your words of wisdom for us, and then I will.
No, sir. I'm just now reached to Patna Airport.
Oh, very good.
Welcome, Dr.
Thank you.
Dr. Thakkar, thank you very
sir.
much. Dr. Thakkar,
Yes, I just reached to the Patna Airport.
And I'm here in Lucknow from Patna. So your words of wisdom, please.
Yes, sir. So we are very much thankful at Indian Orthopaedic Association, and we congratulate IORA for such a beautiful program, and it's a close association with the IOA. And I think this is the first program by Dr. Rajesh Gupta being a president of IORA. So I
Right.
congratulate him, and
Thank you, sir.
I must
Thank you.
thank all the faculty. I must
Thank you, sir.
thank all the faculty for such a beautiful academic program. So this will be very much enlightening to all the IO members. And thanks to all the delegates and listeners for getting into this. Any questions you ask, the faculty are prepared for all the questions. And that will be a more interactive and useful webinar. Thank you all. Thank you.
Thank
Please,
you, Dr.
sir,
Naveen.
please continue
Thank you.
your academic activities, sir.
Right. So what I was talking about, that disease-related autoantibodies, which again Rajesh has said earlier, like ACPA and sometimes rheumatoid factor, and also I was talking about anti-MCV. So they develop much before the clinical features of the disease have appeared, before inflammatory features are there. So minimal features developing at the earliest labels this as unclassified or non-specific disease before symptoms and signs fully bloom into rheumatoid arthritis. Now, early detection of rheumatic diseases or rheumatoid arthritis. So what are the symptoms without clinical evidence of arthritis and denoting the pre-RA phase? So the symptoms could be arthralgia or joint stiffness with, again, positive rheumatoid factor and or ACPA. They can unusually be seen without any evidence of arthritis. After passage of some time, they progress to classical rheumatoid arthritis. So the systemic autoimmunity associated with this disease, that the patient could be asymptomatic with positive rheumatoid factor ACPA, are grouped under this heading. The basis is, as Dr. Rajesh had just now said, antibodies related to rheumatoid arthritis are present in the system prior to the diagnosis of rheumatoid arthritis. That makes it abundantly clear that presence of rheumatoid factor and ACPA are highly specific predictor of the oncoming rheumatoid arthritis. I have just now said that this pre-RA stage, sometimes we would prefer to label it as undifferentiated arthritis. That means there is involvement of more than monoarticular joint affection without fulfilling the criteria of RA or any other connective tissue disease. On long-term follow-up, not all, only 30 to 40% of these patients progress to classical rheumatoid arthritis. So this diagnosis of exclusion does not satisfy, and the classification criteria of a well-recognized rheumatic disease still have the potential for development of persistent inflammatory arthritis. Friends, as I have just now said, that rheumatoid arthritis is a polyarticular disease involving bilaterally symmetrical joints. But to start with, occasionally they can present as monoarticular joint onset. So most common other differentiating points of monoarticular disease like gout, osteoarthritis, and most importantly, the septic arthritis are to be looked into. So most critical diagnosis with monoarticular symptoms must always exclude joint infection. Hence, the rule of thumb is acute monoarticular arthritis, assume infection until proven otherwise, and this joint must be aspirated as well. Now, coming to the classical polyarthritis pattern, there are various names. So, first of all, definite inflammation leads to swelling, tenderness, and warmth. If it is in more than 4 joints, it is called polyarthritis. Poly or oligoarticular arthritis, till the time only 2 to 4 joints are involved. And polyarthralgia is a stage where arthritis has not settled and there is pain in more than 4 joints. Without demonstrable inflammation there may be only diffuse aches and pains, and there is poor localization in a particular joint. Friends, for early detection of rheumatoid arthritis, these are the following typical points, and out of which the history always is very important. I'm in the habit of telling repeatedly that talk and talk to the patient till the patient gives you the diagnosis. That is so very much true in case of diagnosis of rheumatoid arthritis. Physical examination of the joint or joints involved, apart from systemic examination, will also be important. Lab test about this, Dr. Chinmoy is going to deliberate. Radiographic evidence and ultrasound is a tool which also has to be taken help from, and joint fluid examination must not be forgotten. So coming to the joint fluid examination, the inflammatory arthritis in rheumatoid arthritis, the mucin clot is friable, the clarity of the fluid is translucent and yellow, and the most importantly, the cell count is more than 2,000, maybe up to 75,000. Polymorphs are more than 50%, and on culture, the fluid is sterile. Well, bone marrow examination can be of some secondary help. There is mounting evidence, as Dr. Rajesh has said, that osteoclasts are involved in the pathogenesis of a component of the focal bone, and that is the reason why there are focal erosions in rheumatoid arthritis. Well, radiological assessment definitely tells us about the progression of the disease, and this is known as modified sharp 18 method. So there are 44 joints which are likely to be involved, and if there is increase in the score of over 5 in a year, that is an indication of poor prognosis. Well, the criteria, which is not so new now, 2010, ACR and EULAR established this, that this is a score-based classification in which there are 4 major headings. Joint involvement, 1 large joint, and score is allotted for all of them. A smaller joint involvement, they get more scores. Serology, at least either rheumatoid factor or ACPA has to be there. Acute phase reactants, normal CRP, normal ESR, abnormal CRP, abnormal ESR, and duration of the disease less or more than 6 weeks. So out of 10, if the number is more than 6, it definitely is a case of rheumatoid arthritis. Well, I will not talk about the immune response and inflammation because it has already been discussed in very by Dr. Rajesh. But I would like to say once again that these at-risk individuals pass through different stages before they appear with the classical picture. So stage 1, Rajesh has said, interplay of environmental and genetic risk factors. 2, production of autoantibodies like ACPA and sometimes also rheumatoid factor. Stage 3, there could be arthralgia or joint stiffness, but no clinical arthritis. Stage 4, arthritis in 1 or 2 joints, early and undifferentiated, and there is intermittent appearance of pain is pronounced. So this is also known as polyandronic rheumatism. And stage 5, some of these patients develop into classical rheumatoid arthritis. Now, these are the 6 factors which are preventable factors in which Rajesh has emphasized over smoking, obesity, dietary factors, hormonal factors, periodontitis, and infection are others. Well, genetic risk factors he has already discussed in detail. So if at all we have to screen these patients, who are those patients? So use selectively in future amongst number 1, first degree relatives of rheumatoid arthritis patient, autoantibody positive individuals, twins of RA patients, and this screening could cover the population with high disease population. So the spectrum of rheumatic diseases, as I said, rheumatoid arthritis is itself one of the most important systemic connective tissue diseases, and the other ones are SLE, systemic sclerosis, scleroderma, idiopathic inflammatory myopathies, mixed connective tissue disease, overlap syndrome, undifferentiated CTD, Sjogren syndrome, polyarthralgia, myalgia rheumatica, adult onset Still's disease, antiphospholipid antibody syndrome, and vasculitis and related disorders. So friends, I would like to conclude that pre-rheumatoid arthritis is a retrospective diagnosis. This is usually labeled before any stage of the disease, but only retrospectively who have subsequently developed rheumatoid arthritis. So once again, I would like to overemphasize diagnosis of rheumatoid arthritis in early stages, determination of rheumatoid factor, anti-CCP, and the latest in trend, anti-MCV also are useful diagnostic and prognostic tool. So we have to be aware of it, that these could be cases of pre-rheumatoid arthritis or early rheumatoid arthritis. Thank you very much.
Thank you, Professor Jha sir. Such a good information, important information. As if we are making early diagnosing, starting the treatment, we can prevent the deformity in young patient at least. Thank you so much. Now I would request Professor Dr. Chinmoy Das sir for the speech on laboratory investigations in rheumatoid arthritis. Professor Chinmoy.
Yeah, before Chinmoy said,
good evening.
I just one word to say that what Dr. Jha has said, that it is the early sense of suspicion which should be there to keep your eyes open.
Right, thank you.
So it is a clinical one, no? It's a, just sir, if I feel that it is a clinical one. It is a clinical suspicion, high index of suspicion.
And then you investigate, and at the earliest you look for anti-CCP, RA, and anti-MCV.
So, so if it is high index of suspicion, it is not retrospective, it is prospective.
It is prospective, but many a times when these patients are fully blown, and then the patient might have been coming to the same consultant who might have missed it. So then it becomes...
Is there, sir, any literature that the high index of suspicion patient, number of patients are detected, and how many got converted into full-fledged, or how many got regression, or is there any remedy for regression?
Yes. So 30 to 40% of the patients only get converted to fully blown rheumatoid arthritis. And so following the investigations, suppose the mother had it, as I have said, where we could conduct the survey. So if the mother or it is one of the siblings, you investigate, and for some reason you have investigated, patient had no symptoms, and you see that, oh, anti-CCP is positive, rheumatoid factor is positive. So you start thinking...
Sir, is there any trigger? Why did 30-40% also get full-fledged and why others not get? Is there any triggering factor or accompanying factor which has been identified?
Yes, I talked about
if the trigger is stopped, then it can be stopped or not. Is it there anything in the literature?
Yes, definitely. So there has to be control of any upper respiratory tract infection. I have talked also about controlling gingivitis and other any viral diseases also will have to be looked into. So any infection, if you can control them, it may
there is some background noise, sir.
There
is some background noise.
Yes, yes,
there is some background noise. Please mute. Please mute.
or background noise?
Yes, sir, there is some background noise coming. Thank you.
At this moment, this is very important to emphasize to the audience that we should remember rheumatoid factor is only positive in 60 to 70% of cases. So preclinical judgment by identifying a positive rheumatoid factor or a positive anti-CCP is not the end of the story. Most of the time, even the rheumatoid factor has not been there, anti-CCP has not been there, but the arthritis seronegative positive may develop. So a clinical judgment has the most important flag, which we should remember, supported by these investigations. That is the most important thing which should be passed to the audience.
Yes,
Sir, by the,
Manish has rightly
sir.
said.
sir, by the way,
Sir, the issue is, as Dr. Naveen is saying, in the preclinical stage, the pre-rheumatoid arthritis, can we intervene, some way so they don't turn into full-blown rheumatoid arthritis?
Yes, you can start preventive treatment by instituting the DMARD drugs in accurate dose, not a subclinical dose. And maybe I have said the disease might get aborted.
So this is actually what he wanted to ask is, in a preclinical condition, like what I could understand and I could pass it on is, a patient of a hypothyroid, a patient of a diabetes, a patient having a psychosomatic involvement, a patient having a skin allergies, they all are the patients who are going to develop some or other form of the seronegative and positive arthritis. This has to be taken care of by the other specialities, along with, if it is a clear-cut case of a hypothesis there that this is going to be a arthritis, then definitely as DMRD, which is we're going to talk, is at earlier stage can evolve, can stop it. And the publication research says once the patient is on the path, and if the 6 months or 1 year has been passed out, then the patient would be having a long time to go for a remission. It is on. So it is only in the preclinical stage where we can do something, not with the DMRDs, but with other adjuvant treatment, which are the most important one from the other diagnosis.
Manish, what I want to
So it is just like a golden hour. This is just like a golden hour.
Right. So if a patient has anti-CCP positive, that patient has to be caught hold of and kept under regular follow-up, and maybe you start anti-rheumatoid arthritis treatment with DMARDs in their usual dose, and the disease might get aborted.
Yes, sir. Yes, sir. Anti-CCP positive is definitely indication, but rheumatoid factor false positivity, there are hundreds of causes of false positivity rheumatoid factor, starting from tuberculosis, starting from so many conditions, leprosy. So definitely it is the end stage, but if a patient is not clinically having any symptoms, it is only very early stage under positive rheumatoid factor positive, I will never want to give any treatment. Just have to emphasize that be in touch with the consultant, with the doctor, with the orthopedic surgeon, with the rheumatologist, with the physician, anybody, to see when the symptoms come, then the treatment should be started. But when the anti-CCP is positive, definitely yes, the treatment has to be given. But false positive rheumatoid factors are so many conditions with the false positive rheumatoid factors been there.
Think of a situation where a fully blown rheumatoid arthritis mother is coming, and she is accompanied by a very young daughter, and she knows that this disease may be transmitted. So she might ask, or you might start investigating that child also, who still has no symptoms. And one or two investigation that you ask for is the anti-CCP and RA.
Definitely.
So weightage should be given to anti-CCP and not to the RA factor, and not to the clinical symptoms also.
Even Dr. Thakkar, anti-CCP is also not every time positive. If it is positive, it is having a very bad prognostic feature.
Prognostically, anti-CCP says that it is a worst kind of disease.
Positive, rheumatoid factor is not positive, patient is having symptoms, patient is having history, as sir has mentioned, always sir says, it's very important talk. You can find out some loopholes where you require to start something.
Okay.
Sir,
Actually,
So the clear-cut message to the audience is that, I think, can you frame the clear-cut message that when they should start DMRD and when they should not start the DMRD?
Sir, we are having this specifically topic for this after one. So that I think after discussing that topic, we can make a final comment.
Okay.
sir, there is some.
If anti-CCP is
Sika,
present,
please,
they are
mute.
likely to be
Please
present
mute.
in patients whose parents, maybe the mother, is suffering from it. Depending on the symptoms, you might like to follow up these patients. You might like to prospectively treat these patients.
Correct.
sir, one point, sir. Just a minute, sir.
Yes,
Sir,
Amitabh.
Sir,
Sir,
what
you can stop your screen sharing, sir. Jha, sir.
Oh, yes.
Sir, the thing is this, in my short practice, what I have observed, middle-aged ladies who undergoes to hysterectomy, a majority of them post-hysterectomy, they develop this rheumatic factor, all the signs and symptoms of RA. So what is your experience on this? This is in my small practice life, what I have seen. There's late young ladies who goes to early surgical menopause, they develop this.
Osteoporosis is a definite associated disease following early hysterectomy, not necessarily rheumatoid arthritis or maybe even seronegative rheumatoid arthritis.
It has not been
Maybe
there.
under you,
Yeah.
you might have observed it, but it is not so very common.
It's not very common, Dr. Mukherjee, sir. It is simply pain, joint pain, which may be uric acid induced, maybe some other early osteoarthritic changes, which we label to as a rheumatoid arthritis. Truly speaking, it is the most ill-diagnosed arthritis. Either orthopedic surgeon diagnosed directly as osteoarthritis or as a rheumatoid arthritis. But there are so many conditions for the joint pain.
Dr. Neeraj,
Actually,
would you like
sir,
to make a comment?
Sir, I think there is Dr. Mukherjee is saying some hormonal association has been shown. Has been shown. In with rheumatoid arthritis, like in the postpartum period, I was already discussed during breastfeeding. There's some hormonal. What exactly it is, we don't.
Factor.
We don't know.
Many times it is pregnancy,
Naveen wants to
after
say
the pregnancy,
something.
after the delivery, after the pregnancy induced. Patient complains that after the pregnancy they started this. So is it a triggering factor of the pregnancy, as said by Dr. Rajesh Gupta, some hormonal changes? We are not knowing exactly the mechanism, but is there any association with that?
There could be a triggering factor, but we cannot generalize.
Yes.
Okay, we go.
Pregnancy may be a triggering factor as the stress.
Dr. Naveen, pregnancy is a good treatment of rheumatoid arthritis. If a young female is there, if she gets pregnant, the disease itself settles down to some extent. So it is not like a hormonal change in estrogen is going to produce a loss of estrogen is going to produce it. So in my clinical practice also, as Dr. Jha sir has also said, I have never encountered such type of thing. We have a very clear-cut patients who are having a rheumatoid arthritis, and those which Dr. Mukherjee sir is saying, they are the osteoporose patient who are having a late onset of, because there's one more terminology with the due course of webinars, we're going to have it, late onset rheumatoid arthritis, that is post 60 years, that is all a different issue.
Yes, sir. I shall mention it.
Sir, what you are saying is, sir, after the pregnancy, we have seen many patients with the joint pains. Now, whether they are rheumatoid or not, the pains increased. And
No,
that we don't know.
I will tell you, look at it this way. This patient, before getting pregnant, was a patient of rheumatoid arthritis or one of the rheumatic diseases.
Correct.
The disease became quiescent during the period that she was pregnant. After the lactation starts, the disease again reappears. So that could be one observation.
But sir, many patients complain that this polyarthritis or arthralgia has been developed after the pregnancy, after the delivery of 2 or 3 months.
So
I
that
have
is,
encountered the patient.
so that is all with the history of your calcium, vitamin D level, and many of these patients, when we do, the vitamin D is always low. They are all toward the osteomalacia side. And as said, rightly said by Professor Jha sir also, that we have to take a history. Maybe these patients are having a preclinical disease before pregnancy, which is, positive rheumatoid factor, blah, blah, all the things. And then they may be the patients who are coming up. But majority of the patients are due to the joint pain because of the osteomalacia and all those problems. For example, I think everybody of us has seen post-pregnancy ladies coming with a pain in the stelloid process of ulna. I think everybody of us has seen all these patients. They're coming with a wrist pain, especially in the stelloid process. I mean, 90% of the pregnant females complain this, and these are all those patients who are having a little less vitamin D or calcium or some unconditional, hypothyroid or other manifestation which is producing it, or sometimes hyperuricemia. So we can't label it as a rheumatoid arthritis, truly speaking.
Sir,
Okay.
I beg your.
Yes.
Thank you, sir.
Thank you, sir.
Thank you, sir. Thank you very much.
Thank
Thank
you,
you,
sir.
see
All
you
the
again.
best. Wish
Thank
you a
you for
happy
coming.
journey.
Happy journey, sir.
Thank you, sir.
Happy journey,
Happy
sir.
journey, sir.
Happy
Happy
journey,
journey,
sir.
sir.
Thank
Thank
you,
you,
sir.
So
sir.
we
Journey, sir.
continue with Chinmay. Chinmay,
Chinmay sir,
Chinmay sir.
Yeah.
laboratory diagnosis in rheumatoid arthritis.
बोल ही रहे हो कुछ चलो.
सब इतना बोल रहा है इसलिए हम चुप हो गए.
Okay.
Dr. Naveen was saying
हम
we
सोच
should
रहा
talk
था
and talk
नवीन
and
भाई
talk.
का फ्लाइट कितने बजे है. फ्लाइट
चलो,
जल्दी
okay.
होने से अच्छा था.
मेरा
screen
फ्लाइट
करो.
7:30 बजे है सर.
Full
हम
screen.
कराएंगे तब
Good,
तक,
good.
कोई दिक्कत नहीं है. देखिए
Okay.
वेबिनार भी टॉक एंड टॉक पे है, तो लेट अस टॉक एंड टॉक.
Yes, yes. Very, very important, sir. Very important.
Okay. So, good evening, everyone. And today I'm going to present on the laboratory investigations in rheumatoid arthritis. Am I visible and audible?
Yes, sir.
Yes.
Okay. So, what are the aims of a laboratory test? First is your identification of the pathological process in the body and its evaluation of its severity. Secondly, support or negation of a specific diagnosis. When you are in doubt of a diagnosis with your clinical history, as Sir has said, history is the most important. So next comes for a specific diagnostic is laboratory test. And with these tests, we can follow up how the disease and complications can be done, or detection of some adverse reaction of the drug therapy. Interpretation of lab tests should be done only in relation with certain clinical context. It is not that we give tests to each and every patient, because as you know, even in established rheumatoid arthritis cases, rheumatoid factor may be negative. So only 60 to 70%, as Professor Khanna has said, that only 60 to 70% patients, they are positive for rheumatoid factors. And without the clinical pictures, most lab tests are useless. So always the clinical picture and the history takes precedence over your lab tests. So what are the laboratory investigations that are specific to rheumatoid arthritis? Apart from the routine investigations of blood, chest X-ray, then the urine analysis and all those things, you can go for ESR and the CRP, the acute phase reactants, the rheumatoid factor, the anti-CCP, the anti-nuclear antibodies, ANA antibodies, and the synovial fluid analysis. Already these have been partly covered by Professor Jha. So coming to ESR, the most practical indicator in acute phase response is the ESR, but not every inflammation is accompanied by elevated ESR, and elevation of the ESR or high ESR values are related. This is no doubt there is this thing, there is less specificity for the ESR. Sensitivity is less in case of ESR, high ESR, and it reflects mainly the fibrinogen and the immunoglobulins. And the roles are the indicator to organic disease, which may be non-specific, then monitoring the disease activity. This is helpful, and response to therapy can be done with the ESR estimation, where the values for men are age divided by 2, and for women, it is arbitrary, age plus 10 divided by 2. So some of the diseases where you get low levels of ESR and high levels of ESR, in rheumatoid, you get higher levels, anemia, kidney disease. So this is a non-specific indicator of your investigation. Then coming to C-reactive protein, this is a sensitive marker for inflammation. Any inflammation, there will be elevation of the CRP level. And because of the biological ligands, your phosphocholine, phospholipids, and histones, activation of the classical complement pathway, as already described by your Professor Gupta, Rajesh Gupta, and interaction with immunocytes by binding to the Fc portion of the gamma receptors. Rheumatoid factor, a lot of discussion has already gone through with Dr. Naveen Thakkar. So rheumatoid factor, it's only positive on about 60 to 70% of patients, and it can be IgM, IgG, or IgA, but mainly it is IgM and IgG. 85% of patients with rheumatoid arthritis over the first 2 years become rheumatoid positive. So during the course of the disease also, the patient may show positivity. Before it may be, the patient may be negative, but during the course, he may become positive. And the negative rheumatoid factor may be repeated around 6 monthly for the first 2 years of the disease, since some patients may take around 2 years, up to 2 years, to become seropositive. Prognostic value, patients with high titers of rheumatoid factor in general, they tend to have poor prognosis and more extraarticular manifestations of rheumatoid arthritis. So rheumatoid factor, it can be positive in around 50 to 85% of rheumatoid arthritis patients, and Sjogren's syndrome, subacute bacterial endocarditis, SLE, liver disease. This is already covered by Professor Jha. So this is the FC portion where the the proteins, they get attached to form the antibodies. FC portion of your IgM and IgG rheumatoid factors. Then coming to NTCCP, citrulline proteins. So IgG against synovial membrane peptides damaged via inflammatory responses. Then sensitivity is around 60%, and specificity, this is more specific than your rheumatoid factor. Specificity is around 95%, and it has got both diagnostic and prognostic value. So to know the prognosis after treatment, I think there is some background noise.
Dr. Muzumdar sir, please mute. Dr. Muzumdar sir, yours.
Yeah.
Please mute. Thank you.
So NTCCP is also predictive of your erosive diseases with disease severity, radiological progression, and poor functional outcomes. Then comes your ANA, the anti-nuclear antibodies. About 60% of rheumatoid arthritis are associated with positive ANA. Other rheumatological diseases that may be associated with ANA positivity are already, Jha sir has said, that SLE around 95%, and chronic active hepatitis and drug-induced lupus, they are around 100%, they are ANA positives. So again, the specificity for your rheumatoid arthritis for ANA comes down. Acute phase reactants are there. There is mild elevation, ceruloplasmin or complement C3 and C4, then moderate elevation of your hepatoglobulin, fibrinogen, alpha-1 acid glycoprotein, alpha-1 proteinase inhibitors, the marked elevation of your CRP and serum amyloid A protein. And negative phase reactants are albumin and transferrin. Dr. Gupta has already said that there is a relation, genetic relation with rheumatoid arthritis and DR4 and DR1. They are the responsible genes. In the HLA positive in 67% of white population and 30% positive in other than white populations, which is rare in our African population. Synovial fluid analysis, which becomes the cornerstone of diagnosing rheumatoid arthritis. It's a transudate of plasma enriched with high molecular weight saccharides, mostly hyaluronans. Then indications for arthrocentesis is monoarthritis, when the disease is affecting a single joint, usually in older people, older age group above 60 years, the disease rheumatoid arthritis is monoarticular, but otherwise in younger individuals, it's a polyarticular or oligoarticular. Then to diagnose the differentiate it between rheumatoid arthritis and crystal-induced arthropathy, synovial fluid analysis is important, and also trauma and effusion. Already the color, normally it is yellowish, but in inflammatory arthropathy, it can be white or creamish in color, as already has been said by Professor Jha, sir. Viscosity, normally the synovial fluid is highly viscous, but its viscosity is reduced in inflammatory arthritis. Microscopy, sir has already elaborated that normally the cell count is less than 200. Inflammatory arthropathy, it is 2000, it can be up to 2000, and in inflammatory arthropathy, it can be up to 50,000, 2000 to 50,000. And in inflammatory arthritis, arthropathy, the intra-articular hemorrhage, there may be 60 to 80% of PMA. Non-inflammatory arthropathy, it can be mononuclears and your synoviocytes. Other laboratory abnormalities which we get is thrombocytosis, leukocytosis, inflammatory synovial fluid, and hypoalbuminemia. So lastly, I thank you all for your patient hearing, and I request you with folded hands that please vote for Nerosa for IOCON 25. Thank you. Thank you very much.
Thank you, Dr. Chinmoy, sir. Actually, this portion of in the diagnosis of rheumatoid arthritis, I think mostly confusing, whether it is positive or negatives. So thank you so much, sir, for such a good information. And now the most important topic, I think now I invite Dr. Neeraj Jain, sir, for the differential diagnosis of rheumatoid arthritis.
Before Neeraj starts talking, I would like to overemphasize what Dr. Chinmoy has said regarding rheumatoid factor. A patient, fully blown patient, may have initial rheumatoid factor negative, so it is to be repeated times and again at interval of maybe 3 to 4 months till 2 years of the disease. So this becomes very important.
This will
Not beyond.
Yes.
Yes, sir. Sir, you are mute, sir. Neeraj, sir, you are mute, sir. Please unmute yourself.
Dr. Neeraj, you are muted.
Yes, sir. Now, yes, sir.
Is it visible now?
Yes, sir.
Yes,
Visible
please
and
share.
audible. Please share your screen.
Okay, done. So at the outset, I'm really thankful to IORA and Rameshwar for inviting me to be part of the first webinar as told by you, IORA. So like, as I can understand, like the diagnosis has always been made and everything is clear, that is fine with everyone. The issue comes when there is a differential diagnosis, kya ye gathia hai ya nahi hai, all the journey starts from here. So as a consultant, as a resident, we should be always aware of differential diagnosis of rheumatoid arthritis. So in next 10 minutes, I will try to narrow down that like what can be the differential diagnosis we should keep in mind. So as you all know that rheumatoid arthritis is basically a polyarthritis. So we should have some clues for differential diagnosis, and we should be recognizing what are the patterns of joint involvement, and always apart from joint, look for another findings in various systems like lungs, abdomen, CNS, maybe skin, which can give us a lot of clues. So polyarthritis refers to a joint disease that involves at least 5 joints and one or more.
Neeraj, you have not shared the screen.
Please share your screen.
Oh, is it not? Okay.
Yeah.
Sorry.
Yes, yes. Now it's okay.
So I will go back,
yes.
right?
Yes,
I will
sir.
go back.
No problem. No problem. Full screen, please. Yeah.
Is it visible now?
Yes, sir.
Yeah,
Now
great,
it's okay,
great.
sir.
Yeah.
Okay.
So what I was discussing is that rheumatoid arthritis is basically a polyarthritis. So we need to have clues for differential diagnosis, and always we need to find out the pattern of joint involvement to come to a definite diagnosis. And then always we should be like pointing out to what are the other systems involved apart from joints, because rheumatoid is not just a joint disease. It's a disease of maybe a skin manifestation, maybe a lung manifestation, maybe an abdominal manifestation, maybe some lymph nodes are there because of some other disease apart from rheumatoid, maybe some CNS involvement. So we should have a multi-system approach in diagnosing rheumatoid arthritis. Polyarthritis refers to a joint disease that involves at least 5 joints. And we need to look for one or more signs of inflammation, including pain, look for movement restriction, look for swelling, look for warmth, and look for redness are seen in the joint involvements. And in the event that pain is the only symptoms, it is very difficult to diagnose, differentiate between from polyarthritis, because you can just have pain in multiple joints in like fibromyalgia or osteoarthritis. So all joint pains, all polyarthritis is not rheumatoid arthritis. This should be very clear. And also vis-a-vis, all rheumatoid arthritis will not have polyarthritis, as Dr. Jha was telling. So maybe you just have two or three joints involvement, then you have high anti-RFCCP. The duration is more than 6 weeks, and it is high ESR and CRP. You make a diagnosis of rheumatoid arthritis as per ACR-ULR criteria. So it's not that just you need to have 10 joints or you need to have 15 joints to make a diagnosis of rheumatoid arthritis. So also, in some cases of polyarthritis, it can be severe enough to necessitate the admission of patients to emergency services. So we should not take lightly all these polyarthritis. Also, it can be just asymptomatic and remain undiagnosed for months. In last half an hour, we had a very good discussion on what is preclinical RA or what is an early RA. So we need to keep these patients under follow-up. And several diseases ranging from rheumatoid arthritis to infectious disease can lead to polyarthritis. So we need to have a good armamentarium of our differential diagnosis. And as always, Dr. Jha was just pointing out that history is very important. Physical examination, laboratory finding, and imaging methods are the tools that support an accurate diagnosis on top of your good history. So as I said, what are the clues? Demographic data, history, genetic susceptibility, age and gender itself may narrow the potential diagnostic options. In a young male patient, SLE is the last position on the list of differential diagnosis of polyarthritis. So basically lupus is a differential diagnosis, is a good diagnosis for a young female. So if you have a young male patient with polyarthritis, don't keep lupus as a first possible option. Like incidence of crystal arthropathy, maybe gout or CPPD is a higher in older patients. So you keep that in a differential diagnosis. And this condition, polymyalgia rheumatica or a giant cell arthritis, is very commonly diagnosed as rheumatoid because maybe a 70-year-old male or a female which comes with joint pains like in all small joints, large joint, difficulty in lifting shoulders, tiredness, fatigue, and you say, oh, aapko to multiple joint pains, so it's rheumatoid arthritis. So you need to keep that in mind that it is polymyalgia rheumatica because the treatment pattern will change drastically. most important is duration, acute or chronic. ACR-ULR criteria gives a lot of weightage, 2 points and 3 points for acute chronic. See which is the joint involvement. Is it a predominantly large joint involvement? Is it predominantly a small joint involvement? Or does the patient have axial involvement or not? Always see for pattern. What is the pattern? Is it a symmetric pattern or is it an asymmetric pattern? And also see what is the nature of progression of the joint involvement. Is it migratory? Is it additive or is it intermittent? So polyarthritis acute. If it is less than 6 weeks, it is acute. If it is more than 6 weeks, it is chronic. And then the most important thing which I would like to stress here, first of all, make a diagnosis that it is an inflammatory arthritis. So any joint pain more than 30 minutes, if it improves with activity, the symptoms get better. Inactivity increases symptoms. There are spontaneous flares with fluctuation of severity over time without any cause. Constitutional symptoms, inflammatory signs are present. This is inflammatory arthritis. And non-inflammatory is less than 30 minutes. Intermittent, brief rest gets it better. Pain increases with repeated use of the joint, which is totally opposite to an inflammatory joint. There is a gelling phenomena and symptoms fluctuate. This is non-inflammatory. So once we diagnose it acute, chronic, whether it is inflammatory, non-inflammatory, then we come to what the pattern is. Is it a migratory or is it additive or is it intermittent? So at the onset of arthritis, maybe like one or more joints are involved, which improve completely after several days. And following this, another joint is involved, and in this way, polyarthritis occurs gradually. So this is a migratory arthritis. A classical diagnosis we have been taught since childhood is acute rheumatic fever is a classical example of migratory or a shifting arthritis. Additive is joints become involved within days or weeks. This is a classical pattern of rheumatoid arthritis. And what is intermittent? Polyarthritis attacks continues for a while, follows which it completely improves. So this is intermittent. This is very classical of palindromic rheumatism or maybe acute gouty arthritis. We all have seen that the patient suddenly comes with one large joint involvement and then you treat them, or maybe just some NSAIDs, a patient goes and he's fine for maybe 6 months and 1 year before some attacks, another attack occurs. So this is intermittent arthritis. And then what are the common clinical features of common rheumatic diseases? Like if you see rheumatoid arthritis, rheumatoid arthritis is disease of between 40 to 60 predominantly. And psoriatic arthritis, ankylosing spondylitis, reactive arthritis, they are diseases of young, less than 40. Lupus is basically affects mainly small joints, but it is more in the female. So this should be remembered. So these are the ways like how you narrow down your differential diagnosis. Then physical examination, you have classified, always look for weakness, weight loss, fever, always see for skin, always see for eyes, always see for lungs, cardiovascular system, GI system, urogenital nervous system. And now you come to the how you distribute the joint. Is it a peripheral joint? If it is peripheral, is it symmetrical? If it is symmetrical, peripheral, rheumatoid arthritis, lupus, connective tissue disease, vasculitis are very common. If it is basically peripheral joints, if it is asymmetrical, your psoriatic is quite high in the diagnosis. Spondyloarthropathy, the peripheral is mainly facing the patient coming with both knees involvement, ankle involvement, maybe elbow involvement. This is peripheral spondyloarthropathy. Maybe crystal arthropathy is infective, maybe patient coming with sarcoidosis, endocarditis. And now the other part is joint division, which is predominantly axial. Axial, you have spondyle like ankylosing spondylitis, you have an axial psoriatic arthritis, maybe IBD associated arthritis or sarcoidosis. So these are the ways. Is it a peripheral joint involvement or an axial joint involvement? Is it symmetrical or is it asymmetrical? This is very important. And then what are the causes of acute polyarthritis? See, nowadays rheumatoid can present with sudden onset 10 joints involvement. It's one of the common causes. Lupus, very common. Psoriatic arthritis, very common. Then common causes may be like a septic arthritis, maybe arthritis associated with infective endocarditis, reactive arthritis, viral arthritis. We see nowadays we are seeing a lot of chikungunya arthritis. They will come with 1 day history of fever and 10 joints involvement. This is chikungunya arthritis. IBD associated arthritis, acute presentation, patient has diarrhea and then patient gets 5 joint involvement. This is acute arthritis. And then these causes down the line, erythema nodosum, palindromic, they are some rare causes. So what I will narrow down again is inflammatory polyarthritis. If it is a peripheral, RA, lupus should be kept in mind. If it is peripheral oligo, psoriatic arthritis or a peripheral spondyloarthropathy should be kept in mind. And in non-inflammatory arthritis, definitely you people see a lot of osteoarthritis. They come to you with maybe like mainly DIP involvement, that is osteoarthritis. And then hypothyroidism, acromegaly, hemochromatosis, ochronosis, a lot of CPPD, deposition disease. These are other causes of metabolic causes. Then always keep differential diagnosis like multifocal osteonecrosis, polymyalgia rheumatica. We keep seeing a lot of patients with polymyalgia rheumatica, and then nowadays we are doing PET scan in them just to be sure that there is no malignancy, because old age, if you have polyarthritis, always keep malignancy as a differential diagnosis. So that should be remembered. And now I will come to, this is very important, last, and another 3 or 4 slides are beautifully depicted pattern of joint involvement. If you see the pattern of joint involvement in this, these are basically symmetrical in rheumatoid arthritis. If you see shoulder, elbows, wrist, PIPs, MCPs, knees, ankle, very classical. But on the other side, if you see, these are asymmetrical arthritis, shoulder on the right shoulder, the left elbow, the right wrist, the right knee, and the small joints. So these are very classical polyarticular and psoriatic arthritis. So right side, this is psoriatic arthritis. On the left side, this is rheumatoid arthritis. And if you see this is a very classical example of upper limb involvement and the lower limb involvement. If you have predominantly symmetrical upper limb involvement, it is more in rheumatoid arthritis. But if you have a large joint involvement, like knee, ankle predominantly, you have enthesial involvement, you have spine involvement, this is more in spondyloarthropathy. And if you just see the hands of the patient, and then how do you decide? So if you have predominantly PIP and MCP and the wrist joint, it is rheumatoid arthritis. But if you have predominantly predominantly DIPs and PIPs, and then you have CMC joint, it is more of osteoarthritis. So this is the way you narrow down your diagnosis. And this is again a panel in which you see this is classical symmetrical hand involvement in rheumatoid. And this is very classical asymmetrical hand involvement in psoriatic arthritis. So you have a PIP here, the DIP here, and then the wrist here. So this is more in psoriatic arthritis. And if you just see the ankles and the feet of the patient in rheumatoid, it is basically midfoot MTPs, which is involved in rheumatoid arthritis. Osteoarthritis is basically predominantly a first MTP joint, which is more of non-inflammatory. In ankylosing spondylitis or spondyloarthropathy is basically a ankle involvement, asymmetrical. And in another very classical example of psoriatic arthritis is that you people must be seeing like patient coming with a diffuse swelling of the sausage digit swelling. This is very classical of psoriatic arthritis involvement. Gout, we all know, comes with first MTP involvement or what we call as podagra. So now to summarize my talk, what I will do is, once you take the history and physical examination, see whether it is articular. If it is articular or not, if there is no articular involvement, is it trauma, fracture, or soft tissue rheumatism? Our OPDs are 20 to 30% soft tissue rheumatism OPD. So this should always be kept in mind. Yes, if it is an articular involvement, if it is more than 6 weeks or no. So this is, if it is more than 6 weeks, it is acute. So the causes of acute are infectious arthritis, crystal arthritis, reactive arthritis. If it is more than 6 weeks, it is chronic. See for signs of inflammation. If you don't see signs of inflammation, it is a non-inflammatory arthritis. If it is predominantly DIP involvement, CMC involvement, it is basically osteoarthritis. And if you see other signs of inflammation, then definitely it is a chronic inflammatory arthritis. See for the joint involvement. If it is just 1 to 3 joint involvement, it is psoriatic arthritis. If it is more than 3 joints, symmetrical, always keep possibility of rheumatoid arthritis. If it is just symmetrical, but not more than 3 joints, then think of psoriatic or a reactive arthritis. But if it is PIP joint, MCP, MTP, then think of rheumatoid arthritis. So this graphical presentation is very important. You first need to decide whether it is articular or not. Then you decide how much is the time, acute or chronic. Then you decide whether it is inflammatory or non-inflammatory. Then you decide which joint is it symmetrical. Is it oligoarticular, polyarticular? That is very important. Then ultimately you will come to a diagnosis of rheumatoid arthritis. So this, I won't again go into the detail, but this is ACR-ULR classification criteria. As I was just listening to your discussion, and then there was a lot of discussion about rheumatoid factor positivity, CCP positivity. So I would not go into the just that patient is rheumatoid positive or a CCP positive. First of all, we need to see for the titer of a rheumatoid factor and CCP. So what this ACR-ULR classification criteria says that is the titer less than 3 times of the upper limit or not. If it is less than 3 times, you just get 2 points for that. And if it is more than 3 times the upper limit of normal, you get 3 points. For example, now I will say that patient has 5 small joint involvement. So patient has 3 points. Patient has high positive rheumatoid and high positive CCP, patient has 3 points. So you just make a diagnosis of rheumatoid arthritis, it is 6 out of 10. But if patient has 5 joints, small joints, patient has 3, and patient has a low positive RF and CCP, patient has just 2 points. So here this patient has 5 points. And but if it is ESRA normal, CRP is normal, it is less than 6 weeks, so patient, you don't make a diagnosis of rheumatoid arthritis. It is still maybe a preclinical RA, or then you need to follow the patient. So I would say that these are all classification criteria. They are not the diagnostic criteria. So you have to use our clinical judgment, number one. And then maybe if patient is not fitting into the classical rheumatoid, then you just need to follow them. I think I will probably end here, and I will be happy to take questions if any. Thank you so much.
Thank you, Dr. Neeraj, for a wonderful presentation. Excellent.
Thank you, Manish. Thank you.
Thank you, Neeraj sir. Such a good information, and basically it's always a dilemma in making the diagnosis due to this crystal arthropathy, whether it is rheumatoid or spondyloarthropathies. So thank you so much, sir. Now, in the end of this, the management part. So I request Professor Manish Khanna, sir, to please present the treatment modalities, medical aspect of rheumatoid arthritis.
Well, good evening, everyone. I think now the treatment part is to be taken care of. So definitely, as been explained for the last 1 hour, we need to prevent the joint destruction and the crippling. And that is why the entire armamentarium of the rheumatoid treatment, from NSAIDs, from anti-rheumatoid, we all know the adjuvant drugs like steroid, when to be given, how much to be given, for how long to be given. And definitely, yes, the disease-modifying anti-rheumatoid drugs, which include both the conventional and the biological DMRDs. This Bible of Rheumatology, Kelly's textbook of rheumatology, they have an entire armamentarium of all the drugs which we use it, but definitely we should remember that. Okay, so this is the entire range, but definitely we should remember what are the infrequently used drugs before coming for a frequently used drug. So that is azathioprine, D-penicillamine, gold sodium orothiomylate, cyclosporin A, but definitely it has been very infrequently used. So what are these DMRDs are for? What? Actually, these are the drugs that actually should alter the disease course, which they do. These are the drugs that should be used as soon as the diagnosis is made. That is the, I think, the beauty of the all the study and the, what we are doing here and what we are trying to learn for the last 1 decade. Drugs whose appearance of benefit delayed for weeks to months, and that is very important to be explained to the patient that they are not the rocket drugs. You're going to start the DMRDs and they're going to give an effect within a week time or a 2 weeks time. You need to have a good counseling over these drugs before starting to the patient that they are not the rocket drugs, for which definitely we can use steroid or NSAIDs for the time. And these drugs should be continued till a true remission is being achieved. So that is the most important thing to be explained to the patient. Ki bhai, the aram liya, dawa khai, aram aa gaya. It should not be stopped. It needed to be we can't explain everything to the patient, but definitely a remission has to be the final motive of our orthopedic treatment. Well, DMRDs, they retard or halt the progression of disease. I've used both the term retard or halt because sometimes they retard it in the lifespan of the patient, but never the disease comes to a halt stage. Sometimes, luckily, we go for a halt stage for the disease. And aim is finally to decrease the radiographic progression, to stop the radiographic progression. So we have to pick up a drug which will act accordingly. Definitely, yes, initiate the treatment before 3 months of the symptom. Definitely a better outcome is there, as we are discussing. So when to start a DMRD? Definitely, yes, DMRDs are indicated in all the patients with seropositive and negative rheumatoid seronegative arthritis who continue to have an active disease. So active disease is very important. And if the disease is not in an active stage, yes, it can be given, but this terminology has to be taken care of. Usually all such patients with active disease require DMRDs. Only a few of them may undergo self-spontaneous remission. Very, very few patients by the yoga, by the meditation, by blah, blah, all the things together, they have a very early onset of disease and they settle down by itself. So they are very less patient to this. Majority require a treatment. So once the diagnosis is made, the day one has to start the DMRDs. Now, the diagnosis of the RA in early stage is not always easy, as we were just discussing. But as soon as your clue is toward your rheumatoid arthritis or seronegative positive arthritis, as the subject today is around rheumatoid, so we should go for a starting of the DMRD within 6 weeks of the onset of the symptom. If you're able to reach to the diagnosis, DMRDs have to be started. And definitely, yes, nowadays, ultrasonographically, we can also have a documentary evidence that whether the synovitis is there or not. So we know around the world, around the globe, there are so many orthopedic surgeons, so many persons who are using ultrasonographical examination, ultrasonography for the fingers, for finding out the synovitis, for any other joint. That is definitely adding on the symptom in a preclinical stage. Now, next come is how to select a DMRD. So there is no strict, definitely guidelines for how to select a DMRD, that this DMRD to be started or not. But definitely, yes, one should remember that methotrexate has a rapid onset of the action. It is the gold standard drug. So it should be taken into account, provided the patient can tolerate it. Cost is not a problem. And definitely injectable or oral, whatever it may be, it is the first choice across the globe. Should DMRD be given singly or in combination? So this is definitely, we're going to take this slide to in the end actually, because there are so many conditions in which we can pinpoint that this is an aggressive disease like anti-CCP factors and erosion and different criteria. So accordingly, we can finalize whether the single DMRD is to be given or combination. When disease is in an active stage, if HLB27 is positive, RA factor is in high titer, anti-CCP is in high titer, sorry, HLB27 not, anti-CCP is in high titer, then definitely yes, these are the drugs which to be taken care of, and you can find it out whether this is a resistant case, going to be a resistant case or not. DMRD combination is specifically effective if methotrexate is being included because it is an anchor drug. Combination of methotrexate with leflunomide is synergistic but very toxic. So it has to be taken care of since the mode of action is different. So they have a synergistic effect. But definitely, yes, leflunomide is a very toxic drug which should be taken care of. We're going to discuss it in a slide later on. Now, coming to methotrexate, as we all know, that methotrexate is a folate antimetabolite when they inhibit purine synthesis and finally inhibiting the cytokine production and stimulate adenosine release. So initial choice of drug is methotrexate many times because of its rapid onset of action. Why? Within usually 4 to 5, 6 weeks, it produces effect, not before that. So your anti-inflammatory effect for the patient is going to be there after 4 to 6 weeks. That is very important to be remembered. Doses ranging from 7.5 to 15 milligram. And I think we all agree that 10 milligram, 15 milligram, most of the time, which we go usually, rather than for 7.5 milligram, which we go for a maintenance dose. And decreased bioavailability for oral dose may be there. I'm using the term may be there because with the different criterias and with the different research, now it has been very well established that even injectable, even an oral methotrexate is going to produce the same effect as the biological. But in my clinical practice, I have never found it. I find the the injectable preparation is more effective. But yes, since it induces the folic acid deficiency, so it has to be taken care of about the toxic effects. Adverse effects from GI symptoms, from diarrhea, stomatitis, thrombocytopenia, and that is the reason which we ask the patient to go for a proper baseline CBC and LFT count before starting any DMRDs so that at least you can make it out. That is the most important thing. Folic acid may be added from 1 to 3 milligram daily, which decreases the toxic effect of many symptoms like stomatitis. Specifically, we see the patient with stomatitis having methotrexate. So that can be taken care of by folic acid. Contraindication, yes, pregnancy, liver or renal disease, alcohol use, and blood discrepancies. At this juncture, it is very important to inform that unless and until your SGPT, SGOT counts are more than 3 times, it is not very alarming, but definitely it has been seen many times that if you start DMRD, especially methotrexate, there is a transient rise of these liver enzymes, which may settle down. Now coming to my very favorite drug, hydroxychloroquine, which is a very favorite molecule which was used pre-COVID, during COVID, and even after COVID. It can be used in methotrexate in patient with more severe disease, but again, since it has not a very good radiological improvement effect, so it is to be taken care of. It is a least potent but good tolerated drug, recommended for the patient without a poor prognostic features. So without a poor prognostic feature, if your patient is coming without anti-CCP, without erosions, there's so many other criteria which we're going to discuss later on. So then it is a good choice of drug. For any reactive arthritis, it's a good choice. The dilemma, it's a good choice of drug. Doses are 400 milligram usually, can be decreased later on, but I've seen many times that people are using 200 milligrams, so it should be not be like that. The minimal dose is 400 milligram, which is effective usually. It's having a gradual onset of action, takes about 6 weeks or longer to act. In my clinical practice, I see methotrexate and hydroxychloroquine almost the same. And this is a little bit more safer for me to have in all the dilemmas, truly speaking. But further, it takes weeks to have its maximum effect. Again, it is having the same effects, GI tract effect like nausea, vomiting, ocular toxicity. Yes, it has to be taken care of, and rashes, but less often. But it has been reported, so I've mentioned it here. With sulfasalazine, the rashes are more common. Limited monitoring of this drug is to be done, but still the patient of hydroxychloroquine are requested to go for a regular eye examination. But I think I have not seen any patient till now who have a hydroxychloroquine have a retinal changes, but definitely yes, it has been there. Contraindication is definitely a vision changes to the therapy. Now coming to the sulfasalazine. Well, it is again a very common molecule which is broken by the bacteria in the colon to sulfapyridine and 5-aminosalicylic acid. And this is the beauty that it is also having an antibiotic effect, so-called as. DMRD considered to be having almost a similar efficacy or a little lesser actually to methotrexate, especially in spondyloarthropathies. Dosage is 1000 milligram initially, but 1000 BD, that is, it's more comfortable, and I always start with the BD usually in aggressive form. Maximum it can be given to 3 milligram daily also. But if response is very good with 2 milligram, then it is sufficiently and gradually, if you're having a GI symptom and the patient has been settled down, then you can reduce the disease. But the problem is its onset of action is not early. It takes at least 8 weeks to act. That is the most important thing. And again, having the same effects. In fact, the skin manifestation mainly is being seen by the sulfasalazine group of the drugs. And definitely, yes, sulfa allergy. Drug interaction with antibiotics, iron supplements, and warfarin. Now coming to a wonderful but a toxic drug is leflunomide, which is a isoxazole immunomodulatory agent. And it has a very wonderful anti-proliferative activity, but it has to be very cautiously used. It takes care of the anti-inflammatory effect. It inhibits pyrimidine synthesis and making the decreased lymphocytic proliferation. That is the wonderful part. Very aggressive drug for a very aggressive rheumatoid arthritic patient having a poor prognostic features, which you are planning for a biological therapy. Just go and try with this also. And definitely, yes, wonderful evidences are there with a wonderful X-ray, the X-ray deterioration can be altered with the drug. Now, initially, decades back, it was your loading drug was being preferred, like molecules were coming with 100 milligram, 3 drugs, and then, switching over. But gradually nowadays in clinical practice, we are just starting with 10 to 20 milligram. Loading doses not been required so much. It has a enterohepatic recycling mechanism, which prolong its half-life. That has to be taken care of. Cholestyramine has been available in the market for washing its effect if one has been rapidly going for a need for it. But again, it is having a very adverse effect for LFTs and pancytopenia. That is why your repeated counts, CBC, LFT counts every 2 monthly or 3 monthly accordingly. There's no thumb rule for that. But with leflunomide, yes, very aggressively, it has to be managed. And if the patient is on leflunomide and planning for pregnancy, at least 2 years of discontinuation is important, which is again a very important thing to be remembered. Now, if we see the monotherapy, so we have a single drugs like methotrexate, hydroxychloroquine, sulfasalazine. But various drug combinations can be given in the form of a combination therapy, which may be methotrexate with hydroxychloroquine, methotrexate with hydroxychloroquine with sulfasalazine, which is a three drug, which I always prefer in a when we feel that this patient is going to have a prognostic feature back or having a bad prognostic features. Sulfasalazine with hydroxychloroquine is again a very good drug. Methotrexate, hydroxychloroquine, and leflunomide. If you want to add on it, please stop sulfasalazine and add on leflunomide, or you can have a methotrexate with leflunomide also. It works very well, or leflunomide with sulfasalazine, but never all the 4 drugs together. Later on in the combination therapy, when the disease you feel like is going in the remission stage, settling down, again, it's not the end of the story because we see a lot of vaccine running throughout the patient's life. So then we can definitely come down to gradually lower level. In early stages, definitely, yes, monotherapy is very important. But in a country like India, where most of the patients are diagnosed late and coming with a bad prognostic feature, definitely this approach is a challenge. So it's always better to go for a combination therapy. Now, these are the factors which actually make you to decide, like as we have discussed this for the last 1 hour, swollen joint, ESR, CRP, rheumatoid factor, radiographic erosion. Radiographic erosion is a very important thing which you should go for it while deciding your treatment plan. This is a very big topic. It's not possible to cover, but still we're trying to make it very simple. Biological therapy. Now, when to go for the biological therapy? Early aggressive combination therapy in the biological form is important. Challenges with the DMRDs is, since damage can occur very early also, so sometime aggressive approach has been required, has been done throughout the globe by our respective rheumatologists and everybody. Aggressive therapy, they sometimes go for a very beginning actually. But actually the risk of morbidity and mortality of the disease, as been mentioned by in the first lecture also, has to be taken care of. And that is the reason that we need a very good armamentarium while planning a treatment modality for a patient. But definitely, yes, we have to assess the toxicity with the drug. The limitation with the traditional DMRDs is there is a lack of efficacy in some patients. May not slow down radiographic progression depending upon the drug. Durability in the treatment over the long term has been poor. Means now the patient has been very settled down, and gradually after a year time, the patient on these 3 drugs or 2 drugs or 1 drug has not been settled down. Then what next actually? So reduction in the effectiveness of the agent make us to go towards the biological therapy. With the changing trends of the treatment pattern, ACR developed recommendations for the use of biological for early RA. That is true. At least 30% of the patient, 30% of patients fail to receive a ACR level of response. Then what to do? So that is why this biological armamentarium is good. At least 1/3 of the patient with advanced RA do not have a long-term therapeutic option. Again, these drugs are of use. 5 domains must be addressed before planning a biological therapy. What are your indications which you are going to use for? Screening of tuberculosis to be done, monitoring of the side effects when we can do it, assessing the clinical response, and of course, the cost and the patient preferences in the decision making. That I will say very rudely, very humbly, very politely, that many times we don't do the patient preferences, but it is a matter of humanity. We have to take care of that also. And I think this has already been explained. This all 1.5 hour discussion is because of the TNF alpha and interleukin, which have produced this havoc, and the slide being discussed. But definitely biological targets beautifully to specifically these molecules, these TNF or interleukin, or even a T cell or B cell, whatever we want for it. And for this, we have an entire armamentarium. So biological DMRD, they modify the immune response by blocking the effect of pro-inflammatory cytokines like TNF-alpha, interleukin 6, by acting on various immune cells. That is the beautiful part. That is the B cells, or by blocking the activation of T cell, which has been required, because if the T cell and B cell can be taken care of, then I think that things are being settling down. So here's the entire short list of the TNF-alpha antagonist, interleukin 1, and T cells activation suppressors, and anti-B cell monoclonal antibody. So TNF-alpha antagonists, in which adalimumab, etanercept, which is again a very gold standard, infliximab, which was being initially used and it's being used today also, is a wonderful drug. Interleukin 1 antagonist, anakinra, suppressing T cell activation by abtacept, or anti-B cell monoclonal antibody, my favorite, rituximab. So because I feel that when I can take care of my B cells and T cells, especially the B cells, truly speaking, then the things can settle down wonderfully well. Well, in anti-cytokine therapy, TNF-alpha inhibitors and blockers, IL-6 blockers or I blockers, which I have just mentioned. Current place of TNF-alpha inhibitor in rheumatoid management is good. It has a wonderful clinical response, which is very rapid within few weeks of initiating the treatment. To continue the TNF inhibitor, one has to take a feedback properly with all the criteria that whether the drug is acting or not before going for the 3rd month and 6th month of the therapy. Etanercept is a gold standard among anti-TNF-alpha inhibitors. Drug like methotrexate is always a blessed drug, which you can add on whenever you are making the patient coming out of the biological therapy. Now, the problem is when the patient who fails with the TNF-alpha inhibitor, then what? Then you have two things in your choice. Either you can suppress the T cells or you can go for a B cell target therapy. So it's up to the clinician decision. B cell target therapy, I feel very superior, because it reduces inflammation and it has a very good radiographic progression inhibition. And when we can take care of the B cells and the T cells, then I think the job is being very well done. This is coming to the last now. A JAK inhibitor is a wonderful oral tofacitinib. I think everybody knows this, with a 5 to 10 milligram twice daily dose of drug, which is to be used, which is being used, which has been preferred as the most important biological therapy later on, which is comfortable for the patient also in combination with methotrexate. Especially if the patient is not tolerating methotrexate, then yes, it can be continued as such also. But it is, I'm also feeling very sometimes upset that it has been misused by most of us in the clinical practice to use a tofacitinib XYZ very rapidly before, and we have got other armamentarium on the backside. Well, safety considerations with biological DMRDs is serious infection, opportunistic infection, which I've already mentioned, administrative reaction. It is not always, but many times it has been there. CHF, hepatic involvement, vaccination formality. There are so many things. Relative contraindication is active hepatitis B infection. In fact, for all these RA patient, one should go for a hepatitis B and C, but practically we don't unless until we are going for these type of drug therapy. Then multiple sclerosis, active serious infections, current neoplasia, reactivation of tuberculosis, CHF is a common thing, which is again a contraindication. So my take-home message would be the aim of the management has now been moved definitely to the retardation of the disease activity, because only then we are able to prevent the disability. And the realistic goal of early management of RA can only be achieved if the patient is presenting at a right time and we are able to diagnose at a right time with the patient awareness and with the patient proper consent. Thanking you for a very patient hearing. Thanks a lot.
Thank you, sir. Thank you so much, sir, for concising such a big and important topic, the medical part of management. Now, I think Dr. Jindal sir has joined the meeting. Thank you, Jindal sir, and welcome to our first webinar.
Hi, can you hear me?
Welcome, sir. Welcome, sir.
Welcome,
Good
sir.
evening.
Thank you very much for giving this opportunity to be with you and letting me speak about surgery of the hand in a rheumatoid patient.
Yes, sir.
Please, sir. Please, sir. Share your screen.
Yes, sir. Full screen, sir.
Very
Yeah.
nice, Jindal. Welcome.
Thank you very much, Dr. Muzumdar. I'm regularly seeing your videos.
Yeah, yeah. And already this your Manish has already made your way easy, you know.
Yes, I know he's always
Yeah.
helpful.
He has
I
told
am
that
in Odisha right now. I just finished a in hand surgery course here with Prakash Mal. Okay, can you see my slide?
Yes, sir. Yes, sir.
Yeah, very nice.
Please do the full screen, sir.
Full screen.
Go for a slideshow.
You can enlarge it.
सर नीचे बार में होगा सर, वो नीचे बार में
देखो. I have two experts with me who are helping me out.
No, these things happen, sir.
Just click the F5. Click the F5.
So
F5.
IT expert is
Function
here,
F.
sir. Sir, we have IT expert with us.
Function key F5, then it will be full.
Now,
No,
Or you
Not yet,
can
sir.
click from the very beginning, yeah, left side, left upper corner.
You have
from beginning.
slideshow on the top. Slideshow on the top. Yes.
No, it is there already from the beginning. From the beginning.
Yes.
Left side, most
Sir,
left.
yes,
Yeah,
yes.
click that.
Yeah.
okay, now
No, not yet.
No, it has to be enlarged, you know.
enlarge.
No, it will come. It is taking time in your system, I think so.
सर अभी प्रेस नहीं हुआ सर, वो पूरी तरह से. I think beginning पे फिर से जाइए.
अरे नवीन दिन रात ही
I
करता
think
है.
once again, click the slideshow and
Click
then
on the
go
beginning.
from the beginning.
I have asked the remote control to you. Just allow
Okay,
me.
yeah. Naveen is doing remote control. He is controlling me.
Allow me.
Allow.
Thank you.
Is controlling your screen. Wow, how nice. Naveen, you are controlling me?
But your speed is less. That is the problem. It is just moving. See, you can see that it's moving.
Yes, I can see your arrow.
That means it is not Wi-Fi.
Wi-Fi problem. Yes, some Wi-Fi problem at your place.
Okay, I'm at a
Can you
remote place.
Can you? You must be at the remote place. Okay. So I am just putting escape. Just put escape. Okay. Now let us try another measure. Oh, this is different. Same, ne?
Yes.
Okay. Why it is not moving?
सर नीचे नहीं आ रहा बार में, सर बार में नहीं आ रहा नीचे सर.
नीचे आ रहा है बार में, मगर वो क्लिक करते कुछ हो नहीं रहा है वहां. उसके यहाँ कुछ कंट्रोल ऐसा है कि कुछ प्रॉब्लम है उसके यहाँ, इसलिए स्लाइड शो में जाते हैं.
सर ऐसे ही चलने दो सर, ऐसे ही चलने दो.
F5 सर कीबोर्ड पर F5 करिए ना. F5 क्लिक बोर्ड.
नहीं करते फुल स्क्रीन ब्राउज बाय इंडिविजुअल विंडो. ओके करते हैं. कुछ तो उसमें है.
सर स्लाइड मूव कर रहा है, जरा देखो स्लाइड मूव कर रहा है.
From beginning आ गए.
नहीं गोल घूम रहा है मगर जाता नहीं है आगे. उसके कंप्यूटर में वो मेमोरी का कोई इश्यू लगता है.
नहीं सर, इस स्लाइड मूविंग, सेकंड स्लाइड आ रहा है.
नहीं अब वापस एक मिनट हम चेक कर लेते हैं. हाँ सेकंड स्लाइड आता है.
आ रहा है.
सर ऐसे
आ रहा है.
सर
छोटा करके चलो.
तो सर ऐसे डाउन करेंगे, डाउन करेंगे.
ऐसे करो ना, ऐसे चलो ना.
चलने दीजिए.
ऐसे डाउन करेंगे, डाउन करके चलाएंगे.
हाँ ठीक है. चलो ना, ऐसे चलो.
थैंक यू.
कोई मूवी तो है नहीं, कोई प्रॉब्लम नहीं है. मूवी तो है
नहीं.
हाँ मूवी नहीं है.
वो भी नहीं है बस, तो
एक
स्लाइड करके चलाओ,
इसको भी बड़ा कर सकते हैं आप ऊपर।
नहीं सर, छोटा ही रखो उसको। हाँ बस ठीक है।
नहीं ठीक है,
ओके
ओके,
ठीक है सर, अब ठीक है।
ठीक है
एक एक करके चलो।
We'll proceed with the rheumatoid hand surgery.
Sir, just a minute, sir. There is some background noise. Please mute.
सर मुजुमदार सर का बैकग्राउंड चल रहा है
सर,
मेरा म्यूट कर दे रहा हूँ।
हाँ सर, आप म्यूट कर दो।
Naveen, can I proceed?
Thank you, sir.
You can proceed.
Okay. So, as a hand surgeon, I always involve rheumatologists. If Manish or anybody was here, probably they would have been helpful as well, because these medicines are just so many modifications and upgrades are going on, and I am missing
Sir,
them.
some background sound is still there, sir. Please mute.
Sir, आप भी mute कर लीजिए. Please mute yourself also.
Yeah, that is okay now.
So I, as a surgeon, always involve a rheumatologist to look after the medical management of these patients with rheumatological hands. And as has been said about the current concept in rheumatoid hand, the deformities are going down because the medical management is getting better and better and better. And therefore, the number of hand deformities that we are seeing is getting less because of better medical management. There is some kind of a disagreement between the hand surgeon and rheumatologists regarding the indications, timings, and effectiveness of rheumatoid hand surgery. But what I follow, 3 months down the line, if there is no improvement, I offer them surgery. What surgery? We'll talk in a little while. Biologics are used routinely in United States, but are rarely used in United Kingdom, maybe because of the cost involved. Rheumatoid arthritis is a systemic condition that mainly affects the synovial tissue. It affects not a single joint, but multiple joints. And therefore, it is extremely important. You just don't label that the patient is rheumatoid. You said rheumatoid patient with involvement of joint number 1, 2, 3, 4, 5, 6, 7, 8. And therefore, each joint manifests differently to different levels. And therefore, each joint has to be labeled differently, mentioned differently, stages to be identified and treated accordingly. And therefore, the management is not generalized, but individualized as far as surgery is concerned. Each joint, therefore, requires individual management and examination. One joint affects the function of the other joints, like elbow will affect the function of the distal joint, like the wrist and the fingers. And therefore, everything has to be taken into consideration in toto. What are the indications for surgery? The first indication is relief of pain. Once the pain has been taken care of, the next is restoration of function. And the third is the prevention of the disease so that it doesn't become arthritic and cartilage can be preserved. If all these three things can be taken care of, the next thing that is important is the hand should look reasonably acceptable to the patient and the society in general. And therefore, the next thing is aesthetic. The amount of involvement as seen on the X-ray may not correlate with the problem of the patient. The pain is often not related to the degree of deformity. 3 to 6 months of medical management in most patients prior to surgery is recommended. But if some patient, the disease is too severe, surgery has to be intervened much earlier. Despite significant deformity, many patients may report minimum pain. And therefore, deformity is one thing, but if the pain is minimum, it is not necessary they should be operated unless the patient is an important part of decision making. Deformity by itself is not an indication for surgery unless the patient is determined to undergo surgery. What is the incidence of hand affection in rheumatoid? Over 70% of the patient will have hand and wrist dysfunction. For improving function, surgery offers an increase in motion and dexterity, but weakness remains in a significant number of patients. Some caution is used when considering reconstructive surgery in patients with mild deformity, and therefore in mild deformity, desist the patient from undergoing surgery. What therefore becomes surgery, as I said earlier, pain relief and restoration. And next thing is prevention of disease progression. With the advent of DMARDs, rapid joint destruction has become less common. Still, some patients may have pain in the setting of significant synovitis, which has been unresponsive to medical care. Maximum medical management should be in place for at least 6 months prior to proceeding with surgery in majority of patients. In the prevention of disease progression, important thing is significant synovitis and plain not responding to medical management for a certain length of time. In such patient, a good option is the resection of distal ulna if the patient has restriction of pronation supination. One thing that can prevent extensor tendon rupture is an early tenosynovectomy. If you do tenosynovectomy, the amount of extensor tendon getting eaten away by the synovium can be delayed or prevented in total. So other than pain relief and restoration of function and disease progression, the next thing that is important for an indication for surgery is improvement in aesthetic deformity. What it does, it increases the patient satisfaction. In many cases, aesthetic improvements are a natural outcome with correction of subluxated joints and re-establishment of proper anatomical bony alignments. And what are the joints affected? MP joints, PIP joints, and carpal bones. They are affected much earlier and more frequently than the other joints like the hip, shoulder, and the elbow. Smaller joints are thought to be involved partially due to their high ratio of synovium to joint surface area. Certain group of patients are less responsive to medical therapy and experience progressive wrist pain and synovial inflammation. In these patients, early synovectomy and tenosynovectomy play an important role in early management of the disease. And therefore, if the general recommendation is 6 months of waiting period with the medicines. But if some joints are damaging much faster, an early surgery like synovectomy and tenosynovectomy can be done to prevent damage to the joint and the tendons. In most patients, the pattern of onset of affection is the feet, hand, and wrist joints. There are certain perioperative considerations in rheumatoid patient, and that is important in planning the treatment. The most important thing is the cervical spine. Adequate assessment of cervical spine is important to see the stability. Preoperative flexion and extension cervical spine, the lateral view is important to see the stability of the cervical spine. Because if the neck is extended and there is a problem with the cervical spine, hyperextension for intubation can be detrimental to such patient. And in these patients, the anesthetist should be ready for a fiber optic intubation, and cervical collar is recommended to prevent hyperextension injury to the cervical spine during anesthesia. The next thing other than cervical spine is temporomandibular joint involvement can significantly affect mouth opening. And again, that is important for anesthesia. Laryngeal involvement and vocal cord dysfunction with swelling and the mouth opening can affect such patients. It is also important perioperative consideration, the respiratory system, the cardiac system, the renal and the gastrointestinal system in these patients. Patients with long-standing diseases or long-term use of DMARDs are more likely to suffer from pulmonary fibrosis and pulmonary hypertension, and therefore they are at risk of dyspnea and pleural effusion, and that has to be taken into consideration before opting for surgery. Cardiovascular diseases remain one of the primary causes of mortality in rheumatoid patients. They increase incidence of angina, myocardial infarction, heart failure, and stroke. And this again has to be taken into consideration before subjecting these patients for surgery, especially with minimum aesthetic affection. I'll not go into the details, but important to know the side effects of some of these medicines like penicillamine and methotrexate can cause thrombocytopenia, and these things have to be taken into consideration before taking these patients up for surgery. Now, some of the medicines that can be continued or have to be held back, like prednisolone. You can continue to use the prednisolone. Additionally, a stress dose of steroid at the time of surgery may be required to suppress the adrenal response. If these patients are put on steroids, there was no increase in wound problems for patient with steroid or methotrexate or both. But important thing is suture removal in these patients has to be delayed by another 2 weeks at least if steroids or methotrexate are used. Otherwise, the possibility of wound adhesions increases if the sutures are removed in 10 days, 2 weeks time. So what are the types of surgery that are done in these patients? Let's come to the surgical part after theoretical consideration. Synovectomy is one procedure that is commonly done. Synovectomy of the tendons is second thing. Tendon surgery if tendons are ruptured. If there is too much of synovitis, it can compromise the nerve function like carpal tunnel, and that has to be taken into consideration. And the other options, if the joints are involved, if the cartilage is involved, is arthroplasty and arthrodesis. What should be the sequence of surgery? A stable wrist is necessary for successful reconstruction of rheumatoid hand. And therefore, if the multiple joints are affected in the hand, the most important thing is the wrist has to be stable, and this should be tackled simultaneously or should precede surgery in the distal joints of the MP or IP joints. In general, it is more physiologically and more mechanically beneficial to address the wrist prior to more distal joints. Correcting the MP joint deformity before treating PIP joint is recommended. What about combining procedures? You can combine multiple because multiple joints are affected. You cannot afford to take patient for each joint separately, and therefore it is important, being a polyarticular disease, to combine multiple joint surgeries simultaneously to prevent the patient from going to the operation theater again and again. It's important that the nerve is tackled first, especially the carpal tunnel syndrome. If you do not tackle carpal tunnels, the patient can have a stiff hand and can then end up in a reflex sympathetic dystrophy, and therefore decompress the nerve as a first goal and combine this with any synovectomy that you are going to do to any of the joints. Upper extremity compression neuropathy, the commonest is carpal tunnel syndrome. The second is cubital tunnel syndrome, that is ulnar nerve compression on the medial side of the elbow. And patient can have a posterior interosseous nerve that is just anterior to the lateral epicondyle. So all the three nerves have to be considered. Tenderness of the posterior interosseous nerve has to be taken into consideration. Tingling in the small finger, tingling in the other finger is to be considered, and clinical diagnosis is to be arrived at. This is a radial nerve here. This is lateral epicondyle. You are just anterior, and the posterior interosseous nerve is going from medial to lateral side, and it can be trapped under the supinator, and this needs to be decompressed. This is the radial nerve, and this is the sensory nerve, and this is the motor nerve going radially. Synovectomy. If you see fullness here, just tap here and see whether the patient is getting a Tinel sign. This synovitis is affecting the function of the flexor tendon, and this can restrict the flexion of the fingers. So if you take up this patient, you will see the voluminous amount of synovium engulfing the flexor tendons. This will affect not only the function of the fingers, that means the patient will not be able to flex the fingers. In addition, the compression in the carpal tunnel is cause tingling in the fingers, and this can affect the medial nerve function. The sensation can be affected, opposition can be affected. So you do synovectomy, you see the amount of synovium which has just come out of synovectomy of the volar aspect of the distal forearm. The next thing that can come up is the rupture of the extensor tendon, extensor pollicis longus. So while this patient is able to extend the finger, he is not able to extend this finger. This is because of the rupture of the extensor pollicis longus. When the tendon is ruptured, there are options of tendon grafting to primary repair to tendon transfer. The one operation that will work here is will be tendon transfer, because the tendon undergoes the muscle undergoes myostatic contracture. Primary repair is not possible. Grafting will not give the optimum function, and therefore the best option in these patients is tendon transfer. Either you can use a palmaris longus to restore the EPL function, or you can extensor indicis proprius to restore the function. So you see this bulbous proximal end of the ruptured tendon of EPL of this patient. Do not attempt to repair it. Take extensor indicis proprius palmaris longus to restore the integrity of the EPL. So this is the ruptured end here. Extensor indicis proprius is harvested, delivered from this and transferred. So this is the extensor indicis proprius. This is done under a regional anesthesia, IV intravenous regional anesthesia, with tourniquet applied to the proximal forearm. This is the extensor indicis proprius, and this will be transferred to extensor pollicis longus. So you require just few small incisions, transverse incision, and you can repair the extensor indicis proprius to EPL. Similarly, EDC can get ruptured. The patient is not able to extend any of the fingers. Only the small finger is getting extended, others are ruptured. One thing, this was preventable with early diagnosis. If the patient is presented late, like in this patient, you can do, the patient has a flexion, but patient cannot extend. This has happened because the ulna, distal radial ulnar joint affection, ulna has gone dorsally, and EDC are ruptured in these patients. You see, the wrist joint is affected in toto, and so is the distal radial ulnar joint. You do a synovectomy of this patient, and the extensor tendons are brought. The extensor retinaculum is put deep to the tendons. Synovectomy is carried out, and whatever the intact tendon is, to which the rest of the affected tendons are transferred. Attempting to do a primary repair is not possible because the original tendon, original muscle has undergone a myostatic contracture. So you repair the intact muscle to the damaged tendons to restore the function. Extensor retinaculum is brought deep to the repaired tendon so that they do not get damaged further because of the damaged distal radial ulnar joint. Of course, distal radial ulnar joint will require another surgery, maybe in the same sitting or separate sitting. But the important thing is the bone should be kept away from the tendon from further damage. Implant arthroplasty, metacarpophalangeal joint. Yes, all these joints are available, but the problem with these silicone joints is we do not know how many years they are going to last. Of course, a lot of gadgets are coming in our country more and more, but patients are not able to use most of these gadgets. They try to do everything with these hands, and therefore the possibility of these tendons lasting for a very long time is limited. And therefore, every patient in our country asks, how long will this last? And this is a difficult question to answer. And therefore, I dissuade the patient from using these joints. Yes, I'll do a synovectomy. I might relocate the joints. I might let the MP joint stiffen. I'll encourage the patient from using the PIP joint, but using these implants, the patient has to be pre-warned that these implants can break. So these are the silicone joints. Like this patient, the MP joints are subluxated. The good option in these things is do a synovectomy, relocate this thing. If there's ulnar drift, excise the ulnar intrinsic and relocate, and temporarily put the KYS in a relocated finger and encourage the patient from using the IP joints. Transverse incision, MP joint exposed, and do a synovectomy. You see this cartilage denuded joint. Now, if you try to get this movement, this is going to be painful. And therefore, one thing, if it is painless, just leave them alone. If it is painful, you can think about the joint, but pre-warn the patient the joints are not going to last forever. In addition, the ulnar intrinsics are released so that the fingers become more in alignment and ulnar drift is corrected. Okay, so you open through transverse incision all the 4 MP joints. The ulnar intrinsics are cut so that the ulnar drift is corrected. And now you take part of the extensor tendon here and loop it around the capsule so that the ulnar drift is further corrected. You see, the extensor tendon is partly cut and part of the tendon is looped around the radial side of the capsule and wound around and looped back to itself so that other than the intrinsic release, the joint is further corrected from ulnar drift. You see this part of the tendon is looped through the capsule and brought back so that the joint ulnar drift is further passively corrected. Temporarily put a K-wire for about 3 weeks so the joint stiffens in the corrected position after correcting the ulnar drift. Coming to the rheumatoid wrist, it's a cornerstone of hand function, and therefore first thing is the wrist correction before you go on to venture to correct the MP joints. The most important thing that happens to the wrist is the ulnar side affection, because the ulnar tends to dislocate dorsally under the effect of synovial proliferation, and this leads to what is called as a caput ulnar syndrome or dorsal ulnar subluxation. Radial side affection affects much later, but the first affection is ulnar side, and because of the dorsal location of the ulna, the extensor tendons goes attrition rupture. Important thing in this thing is preventive, that is synovectomy. If at all the joint is damaged, there are other options which are available. We'll talk about it. Like this patient, the moment you see this thing, scalloping of the radial side, ulnar side of the radius, there's the first indication that the extensor tendons are likely to get ruptured. The moment you see this scalloping, warn the patient that the extensor tendons are likely to undergo attrition, and at this stage, tell the patients are candidate for synovectomy. Even if it is very early at 3 months medical management, tell the patient this is too late. Just undergo a prophylactic tendon surgery, remove the synovium, otherwise the tendons will subluxate, tendon will go attrition rupture. Now the patient has come later and you see a joint movements are limited, the cartilage is damaged, the bones have become sclerotic, flexion extension is restricted. What you can do is you can do a fusion of the proximal carpal bones to the radius so that the movements occur at the mid-carpal joint only. Once you do this, the pain disappears. Of course, you will do this procedure only if the flexion extension is painful in these patients. But also study the lateral view and you will see the ulna is dorsally subluxated, and these are the patient whose extensor tendons are in rupture. You may not see a scalloping of the radius here, but if the ulna is dorsal, the extensor tendons are at risk of getting ruptured. How about pronation supination? A Save-Kappanji is a good operation in these patients here. If you exercise, do a small limited periosteal opening here, remove about a centimeter of the radius ulna. You can do an early pronation supination. Don't have to do anything to, I do not do any primary fusion of the distal ulna to the radius. Just put temporary K-wires and start early pronation supination, and sure enough, the results are gratifying. Just a small removal, a centimeter of the ulna is removed, and early range of motion to restore pronation supination. This is a close-up of the same thing after reduction of the ulna, early range of motion. This is a close-up of the same thing. Once this has been done, you can go on to do surgery of the distal joints like the MP joints, which I have just mentioned. So what are the options that you can do? I just mentioned about synovectomy. I talked about correction of the drift. I talked of retention of correction by putting K-wires and looping a part of the extensor slip around the capsules. So let's have another example of a ulnar drift of the MP joints in this patient. Sorry, gone? Return to meeting. Is controlling.
Sir, your slide is still seen, sir.
अच्छा यहाँ पे गायब हो गई
यहाँ दिख रही है सर
अच्छा ओके
दिख रही है हमको दिख रही है
चलो तो we have this ulnar drift. Okay, through a transverse incision, open the MP joint. The first thing I just mentioned was removing the synovium. Synovium is the killer of the joint and killer of the cartilage. Remove the synovium. Remove the synovium of all the MP joints As you spread the tissue, all the structures on the dorsum of the MP joint are allowed to slide into the gutter in the intermetacarpal area, so that you don't damage the nerves, you don't damage the veins.
Sir, just a minute. So there is a background noise.
नवीन सर क्या से आवाज आ रही है? नवीन सर क्या से?
मैं निकल रहा हूँ, मेरे को 6:45 पे बोर्डिंग है, सॉरी. हाँ,
Thank you, Naveen.
Thank you, sir. Thank you so much.
Okay.
So nice to see you. Thank
All
you.
right. These intrinsic on the ulnar side are cut so that the drift caused by the shortening of these extensor intrinsics is stopped. You limit the damaging, the deforming forces of the intrinsics. You see these white structures? Just incise these things so that the ulnar drift is corrected. Once you have done this, you can see the fingers are lying into better alignment. The fingers are in better alignment. The next thing that you require to do is this subluxation of the extensor tendon into the gutter, and they have to be brought back into the center of the MP joints. And how do you do this? A part of the slip of the extensor tendon is sutured to the capsule so that the extensor tendon is again relocated onto the dorsal aspect of the metacarpophalangeal joint. So once you have released the intrinsic, you have relocated the extensor tendon, you have relocated the joint. That takes care of the deforming forces, and that brings the finger into a better alignment. So you can continue this surgery on all the 4 fingers, release of the intrinsic, synovectomy, and centralization of the subluxated extensor tendons. So you see now the fingers are better aligned. A part of the slip is used to keep the joint, the extensor tendon relocated into the center. You see, this part of the slip is used to relocate and keep the relocated extensor tendon on the center of the fingers. And this is sutured to the radial side so that the ulnar drift is corrected, and the fingers, you keep it slightly tighter to start with so that the subluxation is prevented. And once you have done this centralization, suture it in place and you can close it. These extensor tendon slips are sutured to the radial side of the capsule. You appreciate this capsule. There's an artery fossa going to the radial side of the capsule. So you suture it to the radial side. Once you have done this, again put this K wires so that it remains in place and healing occurs. Keep it for about 3 to 4 weeks. You let these stiffen to some extent so that the movements occur more at the PIP joints and DIP joint rather than at the damaged metacarpophalangeal joint. Remove it about 3 weeks, 4 weeks with the fingers into alignment. So I think I'll stop at this point. So start with more proximal joint, go to distal joint, start with the wrist, go to the MP joint. Joint replacement does not really work for a long term, and therefore I dissuade the patient from using any of these silicone joints. But synovectomy in early time really helps in prevention of the damage. Save-Kaplange procedure, that is excision of a part of the ulnar sleeve from the distal ulna, is good to restore pronation supination, which lasts for a very long time. So with this, I thank, and I, with your permission, will stop sharing the slide. Is that okay?
Okay, sir.
Thank you, sir.
Okay.
Thank you, sir.
Wonderful presentation.
Yes. I think we are finished with the presentations. Rameshwar?
Yes, sir. Yes, sir.
I think first a few questions to Dr. Jindal.
Yes, I'm there.
Are you on, sir? Sir, the slip you are taking to realign the MP joint, you are taking from the lateral side?
I'm taking from the ulnar side.
The slip you are taking from the ulnar side and attaching to the
radial side of the capsule.
Okay. Okay, over to the reduced side rest.
Yes.
Okay. And sir, if the joints are damaged, isn't it feasible to do the orthodesis instead of doing all this? Putting the K wires.
If I do an orthodesis, it causes further limitation of the movement. If I open the joint and I see the cartilage is minimally damaged, I'll interpose a part of the palmaris longus, what is called as a Tupper arthroplasty. But if it is late presentation, you notice the cartilage is severely damaged, then probably just immobilizing and letting it stiffen works much better than doing an arthroplasty. But our patients always ask one word, Doctor Saab, guarantee hai na kya? How can you give a guarantee? The natural joint is gone and guaranteeing is humanly not possible. And especially even if you have the best of the implants, they don't last. I did a Swanson fellowship. Swanson, the gold mine of joint replacement, and they don't last forever. There's a limitation, and our population uses hand for everything. And therefore,
no, sir. What I'm saying is, sir, in those damaged joints, instead of orthoplasty, can we go for arthrodesis in the functional position?
Fusion?
Yeah.
I'm comfortable with this thing, and it really works nicely. So okay. I don't do fusion of the MP joints. Of the fingers. Sir. Thumb, fine, but fingers, no. But that's a choice. If it is severely damaged, not only damaged, it is painful.
Yes, painful, yeah. Painful, yeah. Okay, thank you, sir. Thank you.
Thank you.
Rameshwar, any question in the chat box?
No, sir. There is no question from chat box.
So we will have few questions to Dr. Manish. Sir, you are here?
Yeah.
Sir, excuse me, sir. Sir, if any question to Dr. Neeraj Jain, sir, please ask, as he has to go, sir.
It's okay.
Sir,
I think it is nicely covered by, Neeraj Jain. More of the questions will be on the treatment side, Anyhow. Dr. Muzumdar, sir, any question to
Thank you.
Neeraj?
Yeah, actually, I have seen Jindal doing this operation.
No, sir, Neeraj Jain. Dr. Neeraj Jain, question to Neeraj Jain.
Question to Neeraj Jain, I don't think any question there. Find out from the chat box if anything is there.
No, sir. No question in chat box, sir. Chat box, sir.
Thank you.
Okay.
Neeraj can go.
Neeraj,
Thank you very much.
Thank you, Neeraj, sir. Thank you. Sir को थोड़ा जल्दी है जाना है, sir. Thank you so much, sir. Thank you, being.
जल्दी जाना है, अच्छा. So Manish and Jindal has done a very nice thing.
You are on mute, sir. Dr. Jha sir is on mute. Actually, he wants to.
Pardon?
I simply said we have crossed more than 2.5 hours, so we can call it a day.
All right, sir. A few queries, very important questions to Dr. Manish.
Oh, sure.
Regarding the treatment part, because those are the practical things, I think. When we call it a remission, Dr. Manish, when you should stop the DMRD treatment?
So for remission, actually, the most important criteria is definitely your stopping of radiographic progression, number one. Number two, your ESR should be now under control and limit. CRP is not being raised. Rheumatoid factor has been settling down. And the most important thing is clinical manifestation, the synovitis, the pain, improvement, the movement, it should be there, provided we are not dealing with a condition with Dr. Jindal has shown that in those conditions, definitely the pain would be there because of degenerative changes.
So can we stop the treatment for a moment then? If we say patient is remission, can we stop the treatment?
For the remission, again, very true, you can stop the treatment. That means if you are moving from 3 drugs, you can go to 2 to 1 and gradually go for a stopping of the drugs, provided we should be very much sure that patient don't have any inflammatory marker like acute and chronic marker signs and clinical improvement has been there. And definitely ESR is a very good marker, which is very early to rise and late to subside actually. And in that case, we can stop the drug and we should tell the patient that we are going to stop the drug and you have to be on toes. We have to be on toes that always we need a regular follow-up so that any signs which may be there, which may be a rise in ESR or rise in CRP or a pain, that can be taken care of and then we can start the drug again.
But what we have found in clinical picture is when we stop the drug, patient is back within 3 to 6 months.
No, sir. So actually, what happened that if we start these drugs on the patient, if the patient is in an early stage without a bad prognostic feature, then the remission is fast and is most sustainable. It stays out there. Patient never come back. Again, they come back after 2-3 years sometime. And that has been seen with the ages of the patient is also less in most of the cases. The age of the patient is less. Again, other point of the story, there is some aggressive management, aggressive form of the disease, which is not going in the remission form. So there is no thumb rule actually. We have seen patients who have gone into remission for a long time. We have seen patients who have gone into remission, then again come back with the active form of a disease. But there is no thumb rule, sir, such in that way.
Thank you.
Jha, sir, your opinion on this, sir?
Jha, sir.
Sir, you are mute, sir. You are mute, sir.
Jha, sir.
Yes. Dr. Manish has been perfectly all right. This may not be, he has rightly said, a thumb rule. It will be guided by the symptoms as well as all the investigative findings. So active markers. And it will vary from case to case as well.
Right, sir. Right.
Sir, second query is regarding the pregnancy.
Sir, Neeraj sir kuch bol rahe hain.
The clinical definition of remission is that the tender joint count should be 1 out of 28. The swollen joint count should be 1, and CRP should be 1. Or what you can do is that what normally we do is a clinical disease activity index and simplified disease activity index. So you combine tender joint count, swollen joint count, patient global assessment, and then physician global assessment. So if it is less than 3.3, the scoring, so then it is called as remission. The same is with simplified disease activity index. So you combine CDI, the clinical disease activity, with plus CRP. So it should come down to less than 2.8.
But Dr. Neeraj, I would like to
answer as Dr. Manish said, it's very difficult. So maybe like we continue the treatment for good 3 years. And after 3 years, if patient is in clinical remission plus CRP is negative, then you start de-escalating the therapy. Maybe like as patient is on methotrexate 15, then you reduce it to 12.5, then 10. Every 3 months, you start reducing by 2.5. So it's very subjective and maybe different for different patient. But I think that's the only way. You just can't switch off from 15 to 0 methotrexate. Patient will definitely relapse.
And over and above, many a times we do not achieve remission.
Yes, definitely.
It is low disease
Yes,
activity.
yeah. I was about to come to that. So the ideal would be a remission, but at least if you achieve a low disease activity, that is as good as a remission in Indian setting at least.
So we should continue with low dose of methotrexate in that
Yeah,
case?
actually, ideally, if you ask me, then most of the patients are on either 5 mg or 7.5 mg or methotrexate, and they do well. Once you start reducing beyond this, then majority of will relapse.
Okay, sir.
It's just like diabetes. It's just like diabetes. If you suddenly switch off the oral hypoglycemics, the sugars will rise. So you have to keep them on some minimum medication. That's it.
Sir, is there any such type of study in some cases when we withdrawn or fully methotrexate or DMARDS therapy, and in some remission cases we are continuing with small dosage of 2.5 or 5 milligram. So the chances of that escalation in what comparisons?
In last 17 or 18 years of clinical practice, only less than 5% patients have been on without any disease modifying drugs. Maybe the disease automatically went into a remission. You can't say actually.
Correct.
But it will be not a good idea to switch off all the DMARDs. But most of the patients after 5 years or 10 years, they will stop. And maybe they're the natural way they are going into remission. But I agree with Dr. Manish. Yahi baat hai.
So Neeraj, I have also seen one thing that the tender joint scoring is sometimes very confusing because
very relative, very operator dependent.
Yeah.
Most important point also is that you have to constantly talk to the patient so that he keeps on coming for follow-up.
They will be lost for 1 year or maybe 2 years. Will suddenly come after 2 years. Doctor साहब वो तो दवाई हमने बंद कर दी थी या.
That also becomes
most of the time. This is the clinical scenario, sir. Dr. Gupta sir, this is the most time clinical scenario. that the
I know,
patient-
but this is very, very important. You know, few of them are we are stopping the drug and then restarting. Few are continuing with the drug. So this is very subjective, I suppose.
Invariably, it is not clinicians who stop the drug.
Yes,
The
yes.
patients become symptom-free. They stop the drug and will come when the symptoms are.
That is why we have to
relapse.
do a wonderful counseling that you should not stop the drug. That is the most important thing, to talk to the patient.
Right.
Since Sir Neeraj is here, I have a question to him. There is some problem with the we people and not problem, controversy regarding starting of the steroid immediately when the disease is detected, and we people we don't start with the steroid, we start with the anti-inflammatory drugs. You take Neeraj.
See, the steroid is itself a disease-modifying drug. So there is no harm in starting steroid, and you need to give steroid for initial 6 weeks at least. Because all these drugs, methotrexate or whatever you say, hydroxychloroquine, leflunomide, the onset starts after 2 to 3 weeks. And the peak onset of action is at around 4 weeks. So if patient doesn't get any relief, so the steroid in low dose is a very good disease-modifying medication. So now the recent paper, 7 days back, 7 days before, there was a good paper in which they say that if you keep it around 5 mg, it's quite good. But if you increase it to 7.5 mg per day prednisolone, then it has a lot of side effects. So maybe we can play with around 5 mg, 2.5 mg, 5 mg low dose steroid. But definitely it has to be used as a bridge therapy rather than putting them on a long-term steroid.
So only problem is what we have seen in the practice is patients they used to continue with the steroids.
Yeah,
then
But
we need
are
to
able to
counsel them.
know. They are able to know that this is a steroid and this is a wonderful drug. So they are able to use it actually.
That is the problem in practice. I'm saying in clinical practice, our practice.
But if we don't use initially, they are going to suffer actually, because and then वो बोलेंगे डॉक्टर बेकार है, 2 हफ्ते हो गए, 3 हफ्ते हो गए, अभी तक तो कुछ भी आराम नहीं आया. So scientifically and logistically also we need to put them.
It is in fact a must.
Yes.
Because as Dr. Manish has said, the drugs are likely to have a latent period.
Yeah, definitely.
So for that latent period, this will be a filler drug.
Only tofacitinib is known to start its action within 7 days. So if you put patient on tofacitinib, the earliest response is 7 days. Pain gets down, the CRP goes down within 7 to 10 days. But that may not be the case with everyone. So because commonly used drug is methotrexate, hydroxychloroquine, sulfasalazine, or leflunomide. So all these are going to take their own time.
And Neeraj, whenever there is a relapse, can we start the steroid again for a few weeks?
Sir, definitely steroid has to be used as a bridge therapy.
Step up, step down.
Yes.
Dr. Rajesh says steroid is just like a medical synovectomy.
Yes, right.
So it has to be used, but it has to be used very cautiously and
very judiciously.
Very fast.
But sir, it is said that it is said, sir, that the normal level of cortisone in our body is about 30 milligram per day, not the secretion.
The body
and in rheumatoid cases, it is decreased by 5 to 10 milligram. So if we are giving in the long term cases this 2 milligram or 4 milligram methylprednisolone, it is not harmful.
No.
The
issue is not. Yeah, issue is not about daily dosing, Rameshwar. It is the cumulative dose. Maybe 2 years if you give continuous 2.5, it's a huge amount of steroid to the patient actually. So yeah.
And secondly,
so we have to be conscious about glucocorticoid induced osteoporosis, and we have to take simultaneous
bisphosphonates or something like that.
In cases of adrenal suppression,
right,
what you do? Because long steroid, if you go for 2-3 years, definitely there will be adrenal suppression.
They will go into adrenal suppression. You are
so
right.
That how will you tackle?
Then you need to put them on the another type of steroid, Hysone or something like that, to cover maybe fludrocortisone. ACTH or maybe fludrocortisone sometimes.
Yeah. And another thing, Dr. Saab, whether there is any role of the controversial role of the ozone therapy in retarding the disease progression.
No, I don't
Number one. Number two, is there anything role of the stem cell?
For rheumatoid, there is no evidence for stem cell in rheumatoid arthritis. Osteoarthritis definitely you have, but not in rheumatoid.
Okay, let's not deviate into stem cell. That is a different subject altogether.
Yes. Sir, 2 more queries just quickly. Dr. Manish, in pregnancy, when to stop and start?
So if the patient is a young female who, if the patient is a young female who has been diagnosed as a rheumatoid, then definitely for a planning of a pregnancy, they should be told about what are the type of the drugs which we are using and when they need to be stopped. Like leflunomide, I've already mentioned, methotrexate, it should be stopped. I think at least for me, again, there is so much controversy in the literature, Dr.Neeraj, for this, but I always prefer one year at least for this methotrexate to be taken care of. What is your take on this?
No, methotrexate is basically you need to stop 3 months prior to planning conception.
True, but still,
and leflunomide is 2 years. Methotrexate is 3 months, and you can continue with hydroxychloroquine. Sulfasalazine is not 100% safe, but you can continue in pregnancy. The only two drugs, hydroxychloroquine
and sulfasalazine. But practically, sir, what I prefer is, I don't know, 3 months is very gray area because of so much teratogenicity and so much issues are there.
Actually, they say two cycles of yeah. So it comes out to be around 3 months.
Yeah.
And sir, lactation.
Definitely, HCQS and sulfasalazine can be taken, and HCQS is the most safest, which can be given during pregnancy along with the steroid short course. In fact, I've seen many patients in which they present with the rheumatoid and some type of things, and then I settle down with a steroid only as a disease modifying drug. Ask them to go for a pregnancy. Don't start DMRDs at this now, because the pregnancy will itself take care of it. And as soon as the pregnancy is over, you start with the hydroxychloroquine and gradually going on increasing it. Because most of the time, this is a very much problematic situation. Young female, recently married, diagnosed with rheumatoid, just planning for a pregnancy, I never start anything. Just go for a steroid therapy. Meanwhile, if I require, again go for a pulse therapy during third month or second trimester, and the things settle down gradually.
Thank you. I think any other questions, sir? So we have covered everything, I suppose. Dr. Manish?
Yeah.
Yes, sir. We have covered everything. Everything.
In rheumatoid, anything left? I think there are so many things.
No, there are some. These type of webinars are just a threshold for the audience to just go through it, and then the books are. I mean, the sky is the limit. I think this.
I just want to add one thing about tofacitinib. Like tofacitinib should be taken very seriously, and all workup for TB and what we do for other biologics should be done for tofacitinib. Zoster should be a big risk evaluation for herpes for tofacitinib. Cardiovascular risk should be, so any patient who is above maybe 60, it should be used with great caution considering cardiac vascular events. That's the message.
Very nice.
Zoster should be very seriously followed up.
That is
but nowadays some people are using without any investigation. No tuberculosis, no viral serology, nothing.
That is giving a very bad name to a very beautiful drug. Actually, it's giving a bad name.
Very misused.
It's a wonderful drug, yeah. But
and it is being done by the orthopedic surgeons.
It is being done by the young orthopedic surgeons.
Young
orthopedic surgeons, especially. So please take care of. I think tofacitinib is not a play game. Actually, it has a lot of risk factors, as been mentioned by Dr. Neeraj also.
Because otherwise, it will get its own resistance in the society, and we will be losing this very good drug.
It will be, sir, gradually.
It will be like antibiotic, Augmentin, or Septum. We give to everyone.
So I think we come to the end of this webinar. Last words from Professor Jha, sir.
You are on mute, sir.
And then Rameshwar, you will say vote of thanks.
Yes, sir. Now I request our Manish Khanna, sir, to please say vote of thank and your future.
Right. Manish should say, yeah.
Thank you so much, all the stalwarts here for rheumatology, like Dr. Neeraj and orthopedic surgeon, our IORA executive team, for this wonderful event, which is very important to give the message to the masses that what are the drugs to be used, how we can diagnose it. And definitely it was A to Z event with the help of Dr. Pankaj Jindal as young orthopedic surgeon are finding out new specialities. Definitely, yes, it is a wonderful specialty of a hand surgery to be involved, but definitely you have to take care of orthopedic medical management part, the diagnosis part, do's and don'ts for the rheumatology practice. Only then it has to be attempted, and then it will be a in-house management of hand or the knee or any other deformities. Thank you so much. And it is a great pleasure to have everybody here, especially Professor Jha sir, who has taken a lot of pains. He is here in Lucknow. We are not able to meet each other. We are planning to meet today, but he is 60 kilometers away from Lucknow, actually. So yeah, Dr. Jha sir, your kind words, sir.
All right. So I would only like to highlight that, yes, as per the desire of our President, Rajesh, we have discussed about rheumatoid arthritis, its management, including the surgical aspect of hand surgery. But at the same time, we must not forget that in initial stages, there will be a lot of mix-up with seronegative spondyloarthropathy as well. So
we will take another webinar for that.
As you have planned, it is going to be the next one, or maybe even later. Thank you. Thank you very much.
Thank you so much, sir.
Thank you, sir. Thank you, everybody
Thank
for
you.
Be sportive and
And new president, many good wishes to you that you have set the ball running.
No, sir, we'll need all your blessings, all seniors' blessings we need for running this. It is not one man show, sir.
Don't worry, everything will be all right. Yeah, yeah.
Thank you very much, sir.
Okay, bye. Good night.
Bye. Good night.